Hello, I'm Alan Weil, Editor-in-Chief of Health Affairs. We're so happy to have you joining us for today's event, Global Lessons from COVID-19, presented in conjunction with the release of the December 2023 issue of the same name that just came out yesterday. I'm incredibly proud of this issue in the different dimensions it covers with respect to COVID-19 and the lessons from around the globe. Papers in the issue represent all regions of the world, and as you will hear in the briefing today, take on many different dimensions of the types of lessons that we need to learn from what we've experienced thus far with the COVID-19 pandemic. Up on the screen, you can see the funders for the issue. I want to acknowledge the Robert Wood Johnson Foundation and the Mark Foundation for their financial support of the issue. They made the issue and the briefing possible. They also have made this issue open access, so you should feel free to peruse the articles and share them with others. We want a maximum possible reach from the content of this issue. When we release a theme issue like this, we also have other sources of content. You can see podcasts or you can listen to podcasts with some of our issue authors. We have visual abstracts for some of the papers. We'll have other events that go deeper into certain topics that we'll be discussing today. You can find links to all of these at healthaffairs.org. I want to let everyone know that we're recording the event and we will make it available within a few days on the website, and the slides that are presented will also be available. Just give us a couple of days to get those ready. The way we run today's event, we're going to have 3 panel discussions. Loosely, we've grouped the papers into 3 categories. The first focusing on planning, particularly strategic planning and modeling. The second looks at vaccine access, distribution, and misinformation. And the third panel is going to look at disparities in protecting vulnerable groups. Within each one of these panels, if you're watching live, will have the opportunity to ask questions. You can type them in the Q&A box. We'll do our best to bring those into the conversation. I can't make any promises, but please keep them brief and topical, and we'll do our best to bring them in to the discussion. That will come after each of the authors provide a brief presentation of their papers. As we move directly into the content, I want to acknowledge the leadership of Mark Jitt and Corinna Mouchereau, who were the theme advisors. They provide direction on everything to do with this issue, going back from the beginning to planning it, through peer review, and both of them are participating in the event today as well. Also want to acknowledge our editors, who were Meg Winchester and Margaret Saunders. They led the process internally at Health Affairs. Do want to note that Meg was going to moderate the third panel and unfortunately has contracted COVID, so I'm going to be stepping in for Meg. And I'll be moderating both the first and the third panel. And I also want to note that 2 of the papers, we had, unfortunately, cancellations of speakers. So those papers will not be included in the event today, but they are certainly available on the website. So as we get started, I'm going to move us into the first panel, which, as I mentioned, looks at the lessons learned from strategic policy planning, looking at modeling and what it did and did not accomplish, and how countries approached planning around the COVID epidemic. I'm going to introduce all of the panelists at the outset, and then we'll turn to them sequentially for their presentations. First, you'll hear from Mark Jitt, as I mentioned, one of the theme issue advisors, a professor of vaccine epidemiology and head of the Department of Infectious Disease Epidemiology and Dynamics, and co-director for the Global Health Economics Center at the London School of Hygiene and Tropical Medicine. You'll hear from Adolfo Luis Rubinstein, founder and general director of the Institute for Clinical Effectiveness and Health Policy. Sei Lim, postdoctoral research fellow at the Harvard T.H. Chan School of Public Health. Pedro Bernal Lara, a health economist at the Inter-American Development Bank. and Christian Herrera, a senior health specialist in the Latin America and Caribbean region at the World Bank. So as I say, I'll turn to each of our presenters sequentially. They'll run through the papers that are included in the issue, and then we'll have some time for question and answer. Mark, with thanks for all you did to make this issue possible, I'll turn it first over to you.
Great. Thank you very much for the introduction and the kind words. And I'm really delighted to be able to kick off this really exciting webinar. And I'm delighted because I can start off by talking about modeling. So, I mean, epidemiological modeling has been used to understand infectious diseases and pandemics for a long time, but I think it really entered the public consciousness during the COVID-19 pandemic. And so the work I'm going to present is really asking, well, to what extent did it help and to what extent didn't it? And was there anything we could learn from this? And really the lessons we're going to learn, I'm going to draw together from, if we can go on to the next slide, from two consortia of modeling groups across Western Europe called the EpiPost Consortium and the ESCAPE Consortium. So really this article brings together 15 authors from 9 institutions and 8 countries in Western Europe. That's the UK, Portugal, France, Belgium, the Netherlands, Switzerland, and Italy. And these were all countries which had the capacity to conduct modeling, but actually took very different approaches to modeling. And so we could, from the collective experience and from actually the different modeling groups working with the national stakeholders, but also coming together to share lessons learned, we could really find out what worked and what worked less well. And so if we go on to the next slide, please, if we go to the next slide, please. One thing we found as we surveyed the different ways modeling was conducted in these countries is that there were very diverse ways to actually organize modeling, and each of them had their strengths and weaknesses. I mean, in the Belgium and in the UK, there was the what's called a modeling consortium approach. I mean, one possibly well-known group is SPIEM in the UK, for instance, which brought together about 10 different modeling groups across the country, each of which independently modeled the COVID-19 pandemic based on questions raised by government, and then came together to reach a consensus to be used to advise the government. A similar picture in Belgium, although with slightly fewer groups. But then others had an expert committee approach where they invited modelers to be part of a wider committee that included maybe epidemiologists, virologists, ethicists, and so forth, to actually directly help to inform, well, to provide evidence to the Ministry of Health or the government. And then the Netherlands took a third approach, which was actually the National Public Health Agency itself conducted the authoritative modeling for the Ministry of Health. And so there were these diverse ways to organize modeling, but actually each of them worked or had strengths and weaknesses, but actually the lessons we learned from them, I'm just going to summarize a few key lessons on the next slide, please. One of them is, well, everyone agreed the next pandemic will be different. There's no point going through the exact same playbook we went with COVID. The next pandemic could be not even a respiratory disease. It could not be a coronavirus. So we've got to be prepared, but not prepared for only exactly the same thing. All the groups, as well as policymakers who worked with them, realized the importance of timely access to data for the modelers to be able to come up with results at the sort of pace that policymakers needed them. The advantage of collaborating between groups and countries so we could learn what worked, what didn't work, you know, what were the strengths and weaknesses of different models, of going beyond just health and realizing that economic growth, education, mental health, these are really key objectives of policymakers that also need to be considered. Closely working with not just policymakers, but also the media and help really making sure that the public, there's good communication and engagement with the public, and actually training modelers and other scientists to really get skills beyond the traditional academic toolkit, because things like skills in media communication, for instance, became so important during this time. And one key lesson, one key quote is really the point that traditional academic structures in academia do need to be reformed so that they appropriately recognize these contributions to things like advice optimizing policy making and public communication, not just producing the papers, producing the science. That's incredibly important, but also using it in order to support the rest of society as much as possible, whenever possible. So that's from me. Looking forward to the Q&A after this.
Wonderful. Thank you for kicking us off. I'll now turn to Adolfo Luis Rubenstein.
Well, thank you, Alan. Thanks, Health Affairs, for this opportunity to present our study, which is Lives versus Livelihoods, an epidemiological, social, and economic impact of COVID-19 in selected Latin America and Caribbean countries. Next, please. As you probably know, our region was one of the regions with the highest COVID-19 related death toll worldwide. And this happened despite, in most of the countries, stringent mobility restrictions that in turn trigger large economic losses. We started in 2020 with sponsorship of the IDB in our region to build a user-friendly, open source, transparent, and interactive platform to inform policy decisions on the the mobility restrictions and the public health and social measures in order to evaluate and assess the preparedness and response of health systems in our region. And this was before the vaccines in 2020. We progressed to another model, taking into account the vaccination uptake and rollout in all the countries. And finally, we started to build an integrated model where we could evaluate the impact of epidemiological, economic, and social impact of the mobility restriction measures that were adopted in Latin America and the Caribbean countries. And for that, we first use a model for Argentina, my country, and then we extend the model for Brazil, Mexico, and Jamaica. And this was sponsored by WHO and then by the IDB. Next, please. Our EPI model customizes the key EPI clinical and policy parameters, and it has the advantage of allowing to modify them according to the specific pandemic trajectory, the policy context, and the vaccination strategy in each country. And the economic model quantifies the GDP loss and the poverty associated with mobility restrictions by incorporating the interaction of the lockdown measures and other mobility restrictions with the behavior of the population. We have incorporated a term, a concept called lockdown fatigue, that is estimated as a time-varying degree of compliance with mobility measures as long as the restrictions prolong over time. The main link between the mobility restrictions and the economic impact works through the reduction in working hours. And this is the link between both models, the EPI and the economic model. And the stringency of the mobility restrictions preclude workers from getting to the workplace that effectively reduce the working hours and produce a GDP loss. Next, please. This is what happened as an example in Argentina. Look at the gap between de facto mobility, the jure mobility restrictions of the regulation, the policy measures on the one hand, and the facto mobility restrictions. As the mobility restrictions extend into, throughout the year, as you can see, the gap increases. Next, please. So the overarching aim of our study was to evaluate the EPI-ECON impact of COVID-19 in Argentina, Brazil, Jamaica, and Mexico through outcome measures such as death. The metrics were death, hospitalizations, ICU, hospitalization, so severe hospitalization on the EPI side, and loss of GDP, poverty, and the distributional impact according to sex and income level of a mobility restriction that were implemented to mitigate the COVID-19 epidemic, and always taking into account the vaccination rollout. Next. This is how the integrated EPI-ECON model works. You can see here in light blue, mobility to the workplace was a link And on the econ side, you can see that lengthy restrictions increase the lockdown fatigue. And as you can see, this will impact the econ model outputs. And as you can see also on the epi side, you can see the lengthy the more lengthy restrictions, the more increase the lockdown fatigue, and reducing the working hours and increasing the GDP loss. On the epi side, the more death in a period of time, like severe disease, death, or ICU hospitalization, create a kind of fear factor that decrease lockdown fatigue. So this is the interaction, a recursive interaction between the econ model and the epi model that impact on the mobility to the workplace, which in turn impact on the GDP loss. And you can see that, of course, the GDP loss will be shaped by informality, which is very common in Latin America and the Caribbean. In some countries, it's more than 50% informality. The fiscal policies, that were implemented in each country, and the safety nets and the labor capacity. Next, please. So the lockdown fatigue is a concept that combines the psychosocial disturbances of isolation and the need to get out, but also the economic needs, the growing income needs, in particular for low socioeconomic status households and informal labor. And this negative relationship between mobility restrictions and working hours works on the decrease with the cumulative effective length of the policy measures on the one hand, but increase when there were, COVID-19 related death. And this results in a non-linear relationship that captures the gap I showed you in a previous slide between the URE and the factor intensity of mobility restriction. Next, please. This is the main results. I will just present a few results. This is a comparison of the trade-off epidemiologic and economic slopes across countries. You can see here that the slope of the trade-off lines represent how much GDP a policymaker has to give up to reduce the death count, what we call a sacrifice ratio. The steeper the slope, the worse in terms of trade-off. For instance, reducing the GDP loss at the margin by 1% will increase the daily death count by 0.5 per million in Argentina, but only 0.3 per million in Brazil. And this may reflect difference not only in the pandemic trajectory, but also in the healthcare system, the economic structure, and the fiscal response in each country. Next, please. And as you can see here, also the change in the poverty rate in the base case, base case is the actual measures that were taken by each country, and the counterfactual scenarios, but in general, relaxed scenarios of restrictions. And you can see we have data here from Argentina, Brazil, and Mexico, not from Jamaica. And the difference between the base case and the counterfactual scenario in each country widens when the stringency of policy measures is heightened. But as the years goes by and the restriction ease and the vaccination uptake increase, both lines tend to converge. Next. In conclusion, among the four countries, Argentina displays a higher GDP loss and a lower death count compared to Brazil and Mexico. That highlights the short-term trade-off that I mentioned before. We observe a larger income loss for women than at the beginning of the pandemic, and also a small differential income loss of lower income workers that typically are in contact with contact-heavy activities and less equipped, lower income workers, to transition to telework. And our results show that the economic impact is uneven across countries, and in addition to the pandemic trajectory, the policy measures, and the vaccination uptake that may reflect differences in the social and economic structures, as well as in the fiscal response to the pandemic. And finally, this interactive and customized modeling platform, and the link is in the paper, can be useful to inform policymakers on the calibration of policy decisions, particularly for future pandemics. Thank you.
Thank you so much. We'll now turn to Siyang Lim.
Right. Hi, everyone. My name is Siyang Lim from the Harvard School of Public Health, and I'm here to talk about why similar COVID policies resulted in different COVID-19 outcomes. So in the first year or two of the pandemic, there was huge variation between countries in per capita COVID-19 death rates, over about 100 times difference. But if you consider the steps that countries took to deal with the pandemic, most countries were dealing with it in similar ways. Now, they had some combination of non-pharmaceutical interventions, NPIs like lockdowns, school closures, social distancing, mask mandates, and so on. So why is it that some countries ended up with far more deaths than others? Now, we found that many seemingly obvious factors do not explain most of this variation. So things like wealth, healthcare capacity, or even age, which matters for individual level outcomes, but not so much at community scale. Next slide, please. So what explains these differences? Next slide, please. So to resolve this puzzle, we used a simple pandemic model with one crucial modification, where we include a behavioral response whereby people take steps to reduce disease transmission in response to the perceived risk of death from COVID-19. So think about an outbreak wave. Click, please. The infection spreads and case counts start to rise, followed by hospitalizations and deaths. And as the situation worsens, eventually governments and people are going to respond by taking steps to reduce transmission. And that's going to curb disease spread, and eventually the wave subsides. Now, eventually, the memory of that threat starts to fade, the interventions are relaxed, and that's going to set the stage for the next wave to begin. So we fit a model that incorporates this behavioral response to data from over 100 countries. And what we found is that ultimately, most countries actually converge to very similar levels of response. So each ends up in this sort of dance with the disease. They take just enough steps to control transmission when it really gets out of hand, and that results in an average long-term reproduction rate of about 1. Now, crucially, the steps that are taken, like social distancing or school closures and so on, are actually very similar across different countries. And that's because everyone is dealing fundamentally with the same disease, which requires more or less the same control measures. Now, where countries differ is in how readily they actually take those steps, so how sensitive they are to the threat of COVID-19. We call this responsiveness as distinct from the response itself. So more responsive countries act faster at lower death rates, and that results in fewer deaths compared to less responsive countries, even though, and this is really important, the NPIs that each may adopt are ultimately going to be similar. And we find that countries vary widely in responsiveness, and it's actually these differences in responsiveness that explain most of the differences we see in long-term average mortality outcomes. We further found that responsiveness correlates with 2 cultural constructs, openness, novelty, and power distance, but it's not a purely cultural phenomenon. So our findings yield several important policy implications. First, they help to resolve a potential point of confusion, which is that if you look at studies of the effectiveness of various interventions, a lot of NPIs like mask wearing or social distancing, they have clear proximal benefits in reducing transmission. But if you look at studies comparing their effectiveness across countries or over longer timescales, often you see mixed or ambiguous results. Now, with our model, we can understand that that's because the long-term mortality outcomes depend less on the specific response measures to COVID outbreaks, because after all, those measures are going to be broadly similar across most countries. And instead, long-term mortality depends more on how readily those responses are actually adopted. Second, if we look at this from a different angle, we can see that greater responsiveness to outbreak threats can save lives without necessitating much more stringent control measures. Because you cannot ignore an outbreak. One way or another, you're going to need to respond eventually, and you're going to need to adopt similar sorts of control measures in the end. But if you try to wait, if you try to put off taking action, you end up with far more people dying, and ultimately you're going to be forced to act to control it anyway. So it's better to act sooner, to act more responsively, and thereby save more lives in the long run for more or less the same level of inconvenience. Finally, some of what determines responsiveness seems to be cultural, but a lot of it isn't. And this is actually good news because deep cultural characteristics are harder to change. So this means that it should be possible for many countries to improve their responsiveness. We haven't dug into this too much in this study, but there are many ways that pandemic preparedness can likely play a role through strong public health operational infrastructure, flexible contingency planning, clear, well-established lines of communication between governments and people about public health matters, and also, of course, a built-up level of trust. These are all things that can likely improve responsiveness. And the good news is these are things that can be developed and practiced in peacetime, so to speak, so that communities are better prepared for the inevitable next pandemic, not just in the traditional aspects of pandemic preparedness, like surveillance, outbreak surveillance, R&D pipelines, and so on, but also taking account of the critical role of responsiveness as well. Thanks for listening, and I look forward to any questions.
Excellent. Thank you so much. We'll now turn to Pedro Bernal Lara.
Good morning, everyone. Thanks for organizing this forum. I'm Pedro Bernal from the Inter-American Development Bank. And I'm going to share with you the findings from this paper where we analyze how disruption in healthcare services that were not related to COVID had consequences for health. And what can we learn from this in Latin America? This is joint work with our colleagues from the IDB. Next, please. So Latin America was hit very hard by the pandemic, although the region accounts for around 8% of the world's population. It accounted for around 30% of the global COVID death toll. And there's a lot of evidence now that there was like substantial disruption in all types of health services, preventive services, outpatient services, emergency, and even hospitalizations. And while the association or the relation between the disruption in services and health is more studied, particularly in Europe and the US, less is known about how this disruption in these types of services influence population in low and middle income countries. So our aim is to provide regional evidence in looking both at how public hospitalizations were affected and their association to mortality for conditions amenable to healthcare in 4 Latin American countries. Next, please. In our study, we focus on 4 middle-income countries from the region: Brazil, Ecuador, Peru, and Mexico. These 4 countries account for around 60% of the population in Latin America. And while their health systems are quite different, they face common challenges. For instance, they have an increasing burden of non-communicable diseases. They have fragmented health systems. There's a large participation of the public sector. Like, for instance, 65% of all hospitalizations in these countries are from public hospitals. And probably the most important challenge, while there have been important progress in terms of coverage and of access of health services, there's still relatively low quality. Some studies estimate about 70% of preventable deaths are related to low quality of care. Next, please. And what are these conditions amenable to healthcare that we focus on? Essentially, these conditions are defined as conditions for which mortality can be averted for people below 75 years old with timely and effective care. There are many lists in the literature of this. We focus on one list from the Pan American Health Organization. And just to give you an idea of what these conditions look like, here in the table, you see, for instance, in non-communicable diseases, you see they include diseases like hypertension, diabetes, some types of cancer, appendicitis, abdominal hernias, and all maternal and neonatal conditions are considered amenable to healthcare. Next, please. Prior to the pandemic, how does this look? Pretty much in our study, 64% of all hospitalizations were amenable to healthcare, and the majority of these are related to maternal and neonatal conditions. And about a third of all deaths of people younger than 74 are amenable to healthcare, and the vast majority of these for NCDs, like 7 out of 10 are NCDs. Next, please. So we use data from these 4 countries on public hospitalizations and mortality on these conditions amenable to healthcare, and we construct rates, age standardized rates per 100,000. We use data mostly at the subnational level from 2015 to 2021, and we consider the pandemic period from March 2020 to December 2021. And essentially, we try to see how health services and mortality were changed during the pandemic period relative to the historical average, controlling for other factors. Next, please. Next, please. So what we find essentially is that we find a reduction of about 4.3 public hospitalizations jointly in these 4 countries, which is like about a reduction of 28% in hospitalizations. And at the same time, we find an increase of around 100,000 deaths for these conditions, which is an increase of around 15%. And the majority of this increase in mortality comes from non-communicable diseases. Around 90% of this increase in mortality comes from these conditions. Next, please. When we break down essentially these conditions into the different types of diseases that are included here, what we find is that there is a decrease pretty much in all types of hospitalizations, in all conditions, and it's also an increase in all types of mortality, except for those defined for children. Like you only find reductions in mortality for neonatal or communicable diseases defined for pediatric patients. And most importantly, what we find is even after we control for many factors like related to COVID vaccinations, COVID cases, the stringency, the COVID containment measures, a decrease of around 28% in public hospitalization, which is what we find is associated with an increase of a 12% in mortality for these same conditions. Next, please. And also really important is that this increase in mortality for these conditions was fairly unequal. What we find is like the poorest states in these countries have the largest increase in mortality. And there's a very clear gradient that you can see from this figure. Next, please. So what do we learn from this? So what we learn is essentially the disruption in essential health services accentuated challenges that the region already had. As a way of example, for instance, in Mexico, prior to the pandemic, like only 1 in 5 patients with hypertension were diagnosed, controlled, and treated. So it's a huge gap in care. And with the pandemic, patients with these conditions had more difficulties accessing care, like any type of care. And as a result, there's also some studies that show that there were increases on patients with uncontrolled hypertension. So since these patients with chronic conditions are really sensitive to gaps in care, there is really no surprise that there's increased mortality from some of these patients as this disruption in care occurred. Next, please. And as I said before, the biggest disruptions were for these patients with non-communicable diseases, mainly cardiovascular diseases, diabetes, and renal failure, and they account for about like 90% of the increase in mortality. Next, please. So what can we learn from all of this? I guess the main takeaway here is that during emergencies, maintaining essential health services is really important, particularly for patients with non-communicable diseases. And if this had been maintained, we have avoided many premature deaths. And the most important key lesson is what can we learn from these countries and what these countries did in terms of how to build more resilient health systems and more resilient healthcare service delivery. So first, what we learn from preparation and response, emergency planning should not just involve just addressing the specific emergency at hand, but actually how to maintain essential health services. And this involves things like identifying the high-risk patients, having governance systems that allow to manage capacity between different networks. And usually they don't communicate, like the public networks and the private networks. It's really hard for them to communicate and actually have capacity available for all types of patients. And also communication with the public is essential. In many of these countries, services were just postponed or canceled like abruptly, causing a lot of confusion and distrust in the public and probably causing delays in care-seeking behavior as well. Next, please. During an emergency, minimizing negative consequences is essential. For this, I guess the importance of maintaining coordinated and continuous care is really important. And many of these countries experimented with alternative modalities of care, like in a limited way, but it's important to learn how can we leverage these alternative modalities of care to provide the healthcare needs, particularly for patients with chronic conditions. For instance, telemedicine was used in some countries like Peru and Brazil to monitor patients with chronic conditions. Some countries experimented also expanding options for medication delivery. In Peru, they had home delivery in medications. In Mexico, they simplified the way medications are refilled. And there's probably like a key role for non-physicians health workers, nurses, community health workers in monitoring these types of patients. And of course, information systems that facilitate case management are really, really essential. Next, please. And finally, after the pandemic and the emergency, the recovery is also really important. What we found is that there's a really a huge reduction in preventive services, and there's a backlog in addressing this. So addressing this backlog in screenings for hypertension, diabetes, and certain cancers is really important, as otherwise we will see more health consequences down the road. And finally, like learning and adapting from what all this entailed is really important. This is probably like the biggest challenge for health systems, to have organizational structures that can actually learn from how healthcare systems fail in providing healthcare for these patients. Thank you very much.
Thank you. And our final presentation in the first panel will be from Christian Herrera.
Yes, thank you very much, Alan. And I think my presentation will be a good complement also to Pedro's and what we have heard before in the webinar. So thank you very much. And what we did with our team in the Latin American region was to focus on routine health services, and try to understand what drove the disruption of healthcare services and how LAC countries responded. So what did they do about it? The next, please. So Pedro also mentioned, but LAC, the Latin American and Caribbean region, was really hard hit by the pandemic. One of the regions with the largest impact, in health, So only 8.5% of the population, 12% of COVID cases, 26% of all COVID-19 deaths, and also 15% of global excess deaths, excess mortality. So all more than the population in the region, but not only on health, also in education. We know school closures was dramatic in the region. And the years learning loss was 1.5, the estimation that was also calculated by the education team in the World Bank. And the economic impact was huge, 7.7% contraction of the regional GDP in 2020, the largest seen in over 100 years, and the worst worldwide was in that year. And of course, what we aim to explore with this study, disrupted health services, the same as Pedro mentioned, virtually in all areas, and for all conditions, this was disrupted. The next, please. The objective of our study was to examine from the perspective of healthcare system decision makers and managers how COVID-19 pandemic affected routine health service delivery, the barriers that they faced to maintain these services, and the strategies they developed over time. And we focused on 8 Latin American and Caribbean countries. The next, please. As I said, well, this is an exploratory qualitative study. We conducted semi-structured interviews from May through December 2022. This was a purposive sample in Argentina, Chile, Colombia, Dominican Republic, Mexico, Paraguay, Peru, and Uruguay. 42 interviews were conducted in these 4 groups. So we went to look for people with responsibilities during the pandemic in public policy making, so at ministries of health, higher levels. Then health services provision planning, also in ministries of health, but also in provincial level, regional levels. And then in the area of provision of services, so primary healthcare and hospital management. So this is the representation across these 8 countries. And in terms of the methodology, we used, from a qualitative perspective, we conducted a thematic analysis of the data. The next, please. So the results first, very quickly, what type of services we divided this in primary healthcare and hospitals now. So follow-up of chronic conditions, mental health, screening and early disease detection, routine vaccinations, prenatal and family planning, dental care. This was some of the widely mentioned, the common mentions from interviewees from all countries. In hospitals, the same. The common were cancellation of elective services, emergency hospital procedures, and medical consultations for specialty, all different specialties. The next, please. Then we move to barriers. What were the barriers? And we divided this from what was pre-existing. So pre-pandemic structural weaknesses that interviewees identified, and the common features across these countries. So we have a basic infrastructure, that it was already weak in the region. Similarly, the health workforce, especially here in terms of numbers, of medical doctors, nurses, and others. Obsolete technology was mentioned at the same time, despite the efforts, but still a problem. And finally, low public expenditure on health. The financing for health still, there is a big gap there, and it was identified as such. Then during the pandemic, there was a lack of funding. It's connected to everything to the pre-existing weaknesses, but lack of funding for expanding services for hiring new personnel, for purchasing medicines, personal protective equipment, and so on. Then telemedicine, of course, was a key strategy, but it still was identified as a problem in many ways. So it was a good thing, but it was problematic for them, for people who were making decisions and managing the system because of the limited capacity. Then one of the strategies that was also mentioned before, the visits, home care, trying to approach services to people as much as possible, but this was rejected. So there was some fear, of course, from the population, and this example of home care rejection is one of those. And finally, misinformation and lack of trust from the population. So it's linked to what was presented before as well. The trust is a key feature that was also identified here. The next, please. And this is to give you an example, one of the quotes from one of the person we interviewed during 2020, he was saying, or she was saying, we did not receive resources to hire additional healthcare workers. So all the personnel worked everywhere. We had psychologists, dentists, nutritionists, delivering medicines in pharmacies and at home, social workers, paramedics as hosts at doors. We all function in all areas. So in practice, providers managed, and they had to innovate in some way. But the final quote, I think it's quite remarkable. We all function in all areas. So they were all trying to cope in the best way possible. The next step, please. Thank you. So then to sustain health services, one of the most important things that was the ministries of health and governments boosted its stewardship role. So they really took a handle of the pandemic. And one of the things that they did was to provide universal coverage in some way for COVID-19 patients. So this regarding the type of insurance they had, if they had insurance, they put together and coordinated public and private provision as well. So that was a big, important change in the system. They obviously reconverted the resources, in particular for hospital. They eased the regulations for hiring and retaining health personnel, authorized the new emergency spending. There is good data of how much that increased during the years of the pandemic. The expansion of telemedicine, and the regulations for that. new strategies to case follow-up, in particular for in non-communicable diseases, for example, and financing policy changes. No, so for example, some countries eliminated co-payments for some services. The next, please. Then to recover, no, that was to sustain, but then to recover when the pandemic started to recede a bit, there was an effort to start recovering health services. So the prioritization was on preventive services and also on rescheduling postponed surgeries. Then they also tried to keep this successful policy of unifying the system, no? That I mentioned before, the public and private sector, with regard to the type of health insurance, and also the use of telemedicine. Mobile facilities was also continued. They tried to retain contracted health personnel. That's even an issue still for some countries, how to do that. And finally, follow-up for NCD patients in primary care was a priority. The next, please. So after that, the policies itself that were implemented had these unintended consequences, you know, of disrupting routine health services. That's something that we know. Then the stewardship role of the Ministries of Health was critical during the pandemic. In emergency times, you need someone to really conduct and to direct and lead the response. And this happened in maybe not in a very planned way, but it happened in practice in these countries. Then in the short term, the priority is to restore and improve the volume to recover these interrupted services. And then they all agree that addressing these structural issues and building resilient healthcare systems was key for future public health emergencies. The next. And I highlighted, this is the last one, the quote that the editors of Health Affairs also put in our paper. No, an important implicit finding of the study was that despite the recognition of the importance of primary healthcare, it was not prioritized during the pandemic. No, and in many ways it was underutilized. And I say this because we are now in Uruguay. And actually, I'm here now with colleagues from the IDB, with colleagues from the Pan American Health Organization and the World Bank, launching an alliance for primary healthcare in the Americas, with this forward look intention of strengthening health systems through primary healthcare to respond to future public health emergencies through resilience. So yeah, I think it's very good that we are aligning into this in this direction to the future. So thank you very much. I think that's the last one, and let's stay in touch. Thank you.
Well, thank you all for those exceptional presentations. I could go in quite a few different directions. I'm going to start a little narrower, but to try to broaden out to some more conceptual issues around the modeling. So the last two papers were really about the effects on health system functioning outside of responding directly to the COVID pandemic as COVID. And so my first question is the degree to which, when we look at modeling done around the world, effects on the health system itself were central to those models. And I might just say that in the United States, we certainly heard a lot about load balancing and efforts to try to close gaps. But when we heard about models, they weren't mostly talking about the effects on the health system per se. So can any of you sort of weigh in on the degree to which that was even part of the thinking of many of the modelers out there, or the models out there? Mark?
Yeah, sure. Maybe I can start. I think that's a great question. And I think the epidemiological models I think were very important in terms of the effect on health system resources. For instance, I think actually for many policymakers, one of the key metrics was to what extent the demand on hospital resources or even intensive care resources, what extent the different policies would cause that demand, and would it exceed the supply in those areas? And so I think, I mean, I would say that that was probably maybe the most important metric in some systems, not to let the health system become overwhelmed. I think where most of the models did not, partly because it was so difficult to predict in advance, but did not do so well, is looking at what effects these interventions would have on hospital demand due to non-COVID related diseases. So for instance, if there's a lockdown, is there restrictions on movements, then, well, some kinds of sort of like health problems will reduce, like maybe road traffic accidents, but others, you know, people will have problems accessing care for things like cardiovascular diseases, and that would cause other negative effects. So I think there were some models that looked at that, but I think that was a sort of underexplored area.
Okay, well, let me broaden out the question here, and I'll just encourage you all to indicate your willingness to jump in. This is a open conversation. So when I'm not a modeler, but when I look at these papers together, I'm left with some puzzles that I'm hoping you can help me think through. One is, Mark, at the outset, you mentioned the importance of sort of interdisciplinary work and the poor incentives of the academic structure. And that would suggest the need for incorporating diverse perspectives in the modeling. There's reference to social context. We've just talked about the health sector ability to respond. But I also imagine that as you add dimensions into the model, you introduce lots of opportunities for error, for assumptions, for feedback loops, how much the economy suppresses but also increases the burden of the epidemic, how much, you know, again, we just had this conversation about health system response. So sitting back, again, it's a very high level question, but it is one prompted by all of these papers. As we think about the lessons, although there's clearly a desire for modeling results that cut across COVID deaths, non-COVID deaths, economic consequences, the health consequences of economic consequences, the effects on health systems, do we gain by trying to predict and model all of those things? Or do we, even though we want that information, do we actually lose because our uncertainty grows and the credibility of the modeling starts to go by the wayside? It's a big question, but it is one I couldn't help but think of as I listened to this variety of presentations. Adolfo, please.
Thank you, Alan. It's a big question, very difficult to answer, but I will try to give you an example of what we did. I mean, in our trade-off, epidemiological economic trade-off models, we try to include both perspectives, the perspectives of not only from modelers, but also from the healthcare perspective in terms of the epidemiological trajectory, the saturation of hospitals, and the death and the prevalence of serious complications with the economic downturn of the policy measures. And we try to create a model, a trade-off model, where you could calibrate the consequences of what you do. I mean, particularly if we think in a future pandemic or a future disaster like we had in the COVID era. And trying to, as I said, incorporate not only, because what happened in my country and many countries in the region, two other presenters, presented what happened in our region. But in general, I would say that there are two behaviors. On the one hand, the safety focus, trying to protect and to save lives, okay? And two, and if you try to protect lives in our conception, what happened in our region was to prolong lockdowns and mobility restrictions and non-essential business and schools closures and etc. And there were other countries that adopted another policy of, okay, we are going to protect lives, but also livelihoods in terms of, okay, we have to calibrate what we do. I think that all of us learn by experience along the way, because many, I wouldn't say that many of the policies that we put in place along the pandemic were based on evidence or were empiric and intuitive, and I would say that all the countries fare the same, at the end of the day. So I think that we have to be prepared for the next pandemic. Hopefully we are not going to see that. Trying to see what happened when we move the lever. If we move the lever up or down, what happened in terms of the pandemic trajectory and the economic consequence, lives versus livelihoods. And I think in our case, our team, our research team was composed of, I'm an epidemiologist and a physician, I'm a family doctor, an implementation researcher, and a former policymaker, if you like. I was Minister of Health in my country. And we had economists, we had behavioral scientists, we have political scientists, and all contribute to how the model was developed to calibrate, in the more precise way, what we would like to show. And this is, I don't know if I respond to your question.
No, I think you did. I'm just interested in some additional takes on this. And I guess I can't help, Siong, but read your paper and think, does it really matter? We do all of this modeling, and as you say, the interventions are similar, and the primary determinant is something that is not typically in the models. So I don't know if you want to expand on that question, on that reaction.
Yeah, in a combination response to what you just said, as well as your earlier question, is there a point to including all of these things in the model? Yes, as long as we're clear about what is going into the model and what the purpose of the model is. By analogy, weather forecast models and global climate models are very different things, but they both have their role. And so it's important, as long as we know, what is the point of what, the model that we're looking at, and therefore what should or shouldn't we include in it. And I think it's important, what we've seen today is that it's important to have a wide range, a diversity of models that address different aspects of the problem. And to your more recent comment, we wouldn't have been able to understand that this responsiveness factor is so critical if we hadn't tried to include that behavioral response in the model in the first place, right? So is there still a role for building a model? Yes, absolutely there is, again, as long as it's fit for purpose.
Very good. I do want to bring in a couple of questions from the audience. Some are a little, one's quite narrow, but I'll ask it quickly also, since Siong, you just spoke. Will you look at responsiveness in relation to long COVID?
I'm not entirely sure what you mean by that, I'm afraid.
Well, I'm reading a question that was submitted by the audience, but I assume it has something to do with as you mentioned, the timing mattering. Maybe that also could potentially be relevant to the occurrence or consequences of long COVID. But I think
to take a quick stab at it, with something like long COVID, where essentially the problem there is that we see consequences long delayed after the cause, right? Long-term consequences, and that's very hard to deal with.
I believe we've lost you, and now you're moving again. So I'm hoping.
Sorry. Basically, delays make it hard to respond appropriately. Short version.
Sorry
in
about
our case. In our case, the same, because we analyze short, trade-offs. So short-term trade-offs. So it's very difficult to answer that question.
Fair enough point. And a question about. Well, I'm going to generalize the question around sort of health system functioning. Are there broader barriers around health system capacity and functioning that perhaps we could have or should have known in advance that would have affected the response? And some of this came out, Pedro and Christian, in your papers, but I'm again going to sort of broaden out the question. What elements of health system capacity are most important for preparation purposes? Anyone want to respond?
I can take that one, Alan. Thank you. No, very quickly. I mean, the feature of resilience, which means be able to prevent, prepare, response, and adapt to emergencies, was not high or very high in the agenda of health systems, to be really honest. The agenda was universal, and is still super important, of course. Universal health coverage, including equity, financial protection, quality, all very important. But the agenda for resilience was not super developed, and was not, and it was mostly focused in the epidemiologic side, which is good, but it wasn't enough. So all the preparation in ministries of health and the studies was around to be prepared, and at least having some basics for example, influenza. There was a big task force for pandemic influenza preparedness. But it wasn't enough, that's for sure. And now we have other threats, other risks that are coming from climate change, from demographic shocks, from conflict and violence, and so on. So that there are other types of risks that will affect health systems for sure. And resilience needs to broaden that focus. And that's the new function that the health system needs to develop with priority. And we are saying here that this has to start from primary healthcare towards the whole health system. That's a focus that we are also proposing now.
A question just came in that actually reflects back, Mark, on I think the first sort of finding that you put up, which is that the next pandemic will be different. So we are very good at looking backwards and saying this is what we got wrong and this is what we should do better. But then the question is, we're probably better prepared if we do all of those things for the next COVID. But if the next if the next pandemic is not, as you mentioned, it could be not a lot of things that COVID was, airborne, and the like. Are the models that you examined and others interacted with able to quickly look at other kinds of potential pandemics, or do we basically start not literally from scratch, obviously, but from a very low baseline of knowledge when something comes that, let's say, is not an airborne, for example, doesn't have airborne transmission?
Yeah, great question. I think this isn't just simply a question about modeling, but the sort of wider infrastructure that was modeling and really policy making, which includes the sort of surveillance, the kind of like public health messaging that goes out. And I don't think there's anything inherent technical that says, and if it's not a sort of like airborne respiratory disease like a coronavirus, then the techniques don't exist. I mean, in modeling, in surveillance, in understanding what are the right measures to do. I mean, we've learned from, for instance, HIV, the HIV pandemic. We've learned from Ebola in West Africa. I think there's just a danger that we shouldn't get our system so sort of firmly locked in one direction, that even though we might have the capacity to deal with other sort of like pandemics due to other forms of diseases, we just get locked into one path. And I think that's why, for instance, CEPI, the coalition that is trying to make vaccines for diseases with pandemic potential, is making a whole range of diseases, ranging from respiratory to sort of viral hemorrhagic to STIs, to what it calls disease X, which is something that maybe nobody really knows what it is. And I think that keeping that flexibility in the modeling world and in all these other areas that contribute to pandemic preparedness is going to be really important.
I'm going to take another audience question and turn it slightly. When we talk about topics as a research, as an outlet for research, people often talk about data and data availability and data limitations. So I'm going to ask this question in a certain way, which is, as you think about the challenges you were facing, is there some type of data that you wished you had that you look back and say, if we'd really understood this, and I'm not talking here clinically, like if we had understood transmission mechanisms earlier, but from an analytic or from a modeling or from a policy perspective, is there something in your work that you sort of came across and thought, this is something knowable that we didn't know, and next time we should make sure we have it? Any thoughts on that?
Well, let me say that I think that Pedro Bernal presented something about the consequences of, for instance, prevention and control of NCDs. We didn't have that data at the time. I mean, the policymakers made their decisions. I mean, the calibration, I mean. And the consequences in excess mortality, for instance, we're going to see it. I mean, we are seeing now, and probably in the next few years in advance ahead. So that was something that I will, I mean, if I finished my term as Minister of Health in my country just right before the pandemic. So, I mean, I was a bit lucky. But if I had been, Minister of Health, I would have liked to see, the whole picture of the measures. I mean, for instance, the policy measures, the mobility restriction, the whole picture of consequences. And I think that we're going to get better prepared for the next pandemic. But but of course, we have to work. Not only the health community, at a global level, we have to work.
Okay, well, Pedro, did you want to?
Just adding something to what Adolfo was saying is that at least what we find, like in our study, is that if you see, like, we study everything until 2021, and that's because many of the data that we actually use for this comes with substantial lags. Like it's publicly available until like a year later, and actually probably higher frequency data of what's going on in terms of healthcare use would probably be very useful as well to inform the modeling and just more broadly, like the understanding of the consequences of the different measures that are being taken in terms of that. So I think that's a really important area to improve on.
That's very helpful. Okay, well, with that, I'm going to thank this excellent panel. I appreciate your papers and your presentations, a nice discussion of everything from small issues to the larger theoretical issues around modeling. It's been great having you. And at this point, I'm going to turn to our second panel, which will be moderated by Karina Mushiro. The panel is discussing vaccine access, distribution, and misinformation. As I mentioned, Dr. Mushiro was one of our theme issue advisors, as an associate professor in the Department of Public Health Policy and Management and the co-director of the Global Center for Implementation Science at the New York University School of Global Public Health. I'll turn it over to you for the next panel.
Great. Thanks so much, Alan. And thanks everyone for being here for this panel. I'm going to introduce our esteemed panelists at the beginning so that there are not interruptions between their presentations. As mentioned, this is a panel on vaccine access, distribution, and misinformation. And our speakers are as follows. First, the panel will open with Peter Hotez, professor and dean at the National School of Tropical Medicine at the Baylor College of Medicine and co-director for the Center for Vaccine Development at Texas Children's Hospital. He'll be speaking on global vaccine access demands combating both hesitancy and inequity. Next, Ashley Fox, associate professor in the Department of Public Administration and Policy at the University of Albany, State University of New York, will speak on substantial disparities in COVID-19 vaccine uptake and unmet immunization demand in low and middle income countries. Third, Bernard Black, the Nicholas D. Chabraja professor at Northwestern University, will speak on the COVID-19 vaccine booster rollout, lives saved in Israel versus the United States, and the cost of caution. Fourth, Rory Smith, Research and Investigation Manager at Brown University, will speak on COVID-19 misinformation interventions, a systematic analysis of effectiveness. And finally, David Ridley, Professor of the Practice and Dr. and Mrs. Frank A. Riddick Jr. Research Fellow at Duke University's Fuqua School of Business, will speak on an evaluation of FDA global drug inspections in the COVID-19 era and beyond. I will hand it over to our speakers. We'll do question and answer at the end. Over to you, Dr. Hotez.
Well, thank you so much, and appreciate having the opportunity to speak for 5 to 7 minutes. Just giving a quick overview. The first slide, please. Next one after that. So I'm an MD PhD vaccine scientist. Did my MD PhD at Rockefeller and Cornell 40 years ago, where I started working on a human hookworm vaccine that's now in phase 2 clinical trials, which is actually looking really promising. That's oftentimes the time frame for vaccines. And then we turned our attention to COVID and made 2 low-cost COVID technologies. The point is, 40 years ago, that was the plan, to be a vaccine scientist, pediatric vaccine scientist, making vaccines. The unplanned part was having 4 adult kids, including Rachel has autism and intellectual disabilities. And I wrote the book, Vaccines Did Not Cause Rachel's Autism, which wound up making me public enemy number 1 or 2 with anti-vaccine groups. But it gave me a front row seat to watch how this movement evolved. So unfortunately, I became not only an expert in the vaccine science, but also the anti-science. And that's what I'll talk about now. Next slide, please. So our vaccine center at the Texas Medical Center, Texas Children's Hospital and Baylor College of Medicine, is co-headed by myself and my science partner for the last 20 plus years. And I like to say we make the vaccines that the big pharma companies would not ordinarily be interested in making, because they're for poverty-related neglected tropical diseases such as schistosomiasis and hookworm and Chagas disease and leishmaniasis. And then around 12 years ago, we started developing coronavirus vaccines for SARS and MERS, severe acute respiratory syndrome, Middle Eastern respiratory syndrome, because at that time there wasn't much interest in those vaccines. So we took them on because they were orphan like parasitic disease vaccines were. And then we were able to pivot our program when the COVID-19 sequence came online in January of 2020. Next slide. And we do a lot of cutting edge technologies like mRNA and particle vaccines, but we also do this. We partner with vaccine producers that belong to what they call the Developing Country Vaccine Manufacturers Network. There's about 40 of them in Asia, Africa, and Latin America, and they all make their own recombinant protein hepatitis B vaccines, or many of them do, which is an older technology, microbial fermentation and yeast. It's very low cost. It's accepted by parents who have been giving recombinant hepatitis vaccine for decades, and simple refrigeration, great safety profile. So it checks a lot of boxes for global health vaccines. And that's what we've been doing for our parasitic disease vaccines. And that's what we did successfully for our coronavirus vaccines, including COVID. Next slide. And so this was the problem that we faced in 2021. I was getting frantic phone calls from ministers of health and ministers of science in low and middle income countries where you ever see the big bubbles there. This is a bubble map of the unvaccinated world on the African continent, South Asia, India, Southeast Asia, Indonesia. And the problem that I see, it was a science policy failure, that there was so much emphasis on speed and innovation, meaning mRNA vaccines, particle vaccines, adenovirus vectored vaccines. And we got some really interesting vaccines. But the problem is, any engineer will tell you, when you go from 0 to 15 billion doses, there was a learning curve. And so what happened was predicted and predictable. Enough doses were made to get bought up by North American countries, US and Canada and Western Europe and Japan. And that really left the African continent, India and South Asia and Southeast Asia out in the cold. And the world paid a price for that, because Delta arose out of an unvaccinated population out of India and affected us, and as well as Omicron out of undervaccinated populations in Africa. Next slide. So we worked with several ministers of health and science globally and licensed our technology for recombinant protein COVID vaccine to India, Indonesia, Bangladesh, countries in Southern Africa, and India went the furthest. Their big vaccine producer in Hyderabad Biological E scaled it up and produced our technology. It's known as Corbevax, and the 75 million adolescent kids doses went into adolescent kids, another 10-12 million adult boosters, and similarly in Indonesia, which made a halal version known as Indavac, and over 100 million doses got administered. So it provided proof of concept that you don't have to be a big pharma company to still do big things in the vaccine space. Not to demonize the pharma companies, but a key point of the paper is we need alternative pathways, and so that we're not totally reliant on big pharma companies. And I think through our product development partnership at Texas Children's Hospital and Baylor, working with developing country vaccine manufacturers, network members, we think that showed it was possible. Next slide. Now, the world is starting to look at what happens as over the next decade, and this is where we switch gears to combating the anti-vaccine activism. Because of the social disruptions, because of COVID, as well as some of the diversion of resources, there have been now big gaps in our steady progress to vaccinate the world's children over the last 2 decades. So the World Health Organization has now put up this Immunization Agenda 2030, which they call the big catch-up. Next slide. And it's starting out pretty rough, that we've had some reversals in our ability to vaccinate the world's children because of those social disruptions and diversion of resources. But something else is happening, as I like to say. That's me in the monk painting over there, that we've had this superimposed on top of that is this new rise in global anti-vaccine activism that's preventing us from getting to baseline. So I just want to finish the couple of slides showing how I think that anti-vaccine movement has evolved or devolved. Next slide, please. And so it started as version 1.0 with false claims that vaccines cause autism. And that started in the late 1990s. That thread's still with us. But then about 7-8 years ago, it became more of a political movement around health freedom, to talk about that. And then finally, the globalization, the empire. Next slide, please. So even within version 1.0, vaccines causing autism, there's a lot of shifts in that. The original assertion that came out of a paper in The Lancet in 1998, that turned out to be false. It was a study in 12 kids, falsely claimed that measles, mumps, rubella vaccine, the MMR vaccine, live virus vaccine replicated in the gut of kids to cause pervasive developmental disorder or linked to it. That was shown not to be the case through large cohort studies. But then anti-vaccine groups began monetizing the internet, selling phony autism cures, nutritional supplements, and anti-vaccine books on Amazon. So they kept on switching up what their actual assertion was. Then it was thimerosal preservative that used to be in vaccines, or spacing in vaccines, or alum in vaccines. So you got into this battle of whack-a-mole, or always moving the goalposts. Then they said it was HPV vaccine that was causing infertility or autoimmunity. And if that sounds familiar for COVID-19 vaccines, that's where they got it from. They copy-pasted the false assertion from HPV onto COVID-19. Next slide. And that's how I got involved, because of having my daughter Rachel and writing the book, which did a deep dive showing the evidence there was no link, and also what autism is, how it begins in early fetal brain development through the action of autism genes. So that we were able to provide a narrative. We did whole exome genomic sequencing on Rachel, and my wife Ann and I to find Rachel's autism gene. The point is, there was a sound alternative explanation. So that did take some of the wind out of sails of anti-vaccine groups, but they came up with something else. And like so many movements in the US, it started in California, but amplified in Texas. So by the 2010s, so many kids were not getting vaccinated that there was a breakthrough measles epidemic. The California legislature said this is not a good idea to allow vaccine exemptions. They shut it down. I agreed with it. It solved the autism problem. But then there was a counter reaction around this concept of medical freedom. And that's what it took off in Texas. Next slide. And in Texas, unfortunately, this translated into COVID, where almost that green arrow shows when vaccines became widely available during the Delta BA1 wave. Almost as many Texans died after vaccines became available as before because so many Texans refused a COVID vaccine. 40,000 Texans needlessly perished. 200,000 Americans needlessly died. And this is in the paper because they refused a COVID vaccine. And then the next slide. And ultimately, they were victims of politics. This is from Charles Gaba, the health analyst. Looking at that Delta wave on the right, almost all in red states, and the redder the county, the lower the immunization rate, higher the death rate, so much so that David Leonhardt, the New York Times, calls it a red COVID. So how we talk about that is really tough. This started at the CPAC Conference of Conservatives in July of 2021. First, they'll vaccinate you, then they'll take away your guns and your Bibles. And as ridiculous as that sounds to us, people in my state of Texas accepted that. And then members of the House Freedom Caucus used very aggressive anti-vaccine rhetoric. Senator Rand Paul, Senator Ron Johnson, amplified every night on Fox News. And this was documented by two groups, Media Matters, as well as a research group out of Switzerland. Next slide. I'll finish to say that, and we can maybe talk about more of this in the discussion. The point is an organized, predatory, well-financed movement linked to party politics in the United States. And unfortunately, that US-style anti-vaccine activism is now globalizing. We're starting to see that same US-style anti-vaccine rhetoric, not only in Canada and Western Europe, but also in low and middle income countries, on the African continent, in Asia and Latin America. So this is now a globalizing phenomenon, version 3.0, and this is the new book I've written to go along with it, The Deadly Rise of Anti-Science, which goes into a deep dive explaining how all this came about. So thank you so much for the opportunity, and I look forward to talking more at the panel. Thank you. And now turn it over to Ashley Fox.
Great. Thank you so much. And thank you for having me here today. That was a really helpful setup that Dr. Hotez gave for our topic, which is on substantial disparities in COVID-19 vaccine uptake and unmet immunization demand in low and middle income countries. So I think what makes our study a little bit unique is that, unlike many studies that have examined vaccine hesitancy or willingness to vaccinate, our study is one of the few that have looked at actual vaccine uptake at least 1 year after vaccines became widely available for public consumption across all population age groups in low and middle income countries. So what our study tries to do is to examine vaccine uptake across 17 Western Pacific and African countries through nationally representative surveys. And the primary goal of our study was really to tease apart these kind of two separate phenomena, but basically the extent to which inequities in vaccine supply have resulted in lower than desired uptake, so what we're calling unmet demand, and how much of low uptake has to do with population hesitancy or low demand for vaccines. So as shown in this slide, basically what we found was that actually many Western Pacific countries achieved near universal vaccination, with greater than 90% of the population receiving at least one dose, and large majorities receiving 2 or more doses. But by contrast, in sub-Saharan Africa, only about 50% of the population in the countries that we surveyed had been vaccinated on average, and only 20% had received boosters. Primary vaccination rates were less than 50% in 4 African countries that we looked at. And across all countries, only 22% of the sample had received the more efficacious mRNA vaccines that were quite widely available in high-income countries. Next slide, please. So when examining this phenomena of unmet demand for vaccines, in other words, how many people wanted to be vaccinated but weren't, interestingly, what we found was a pretty even split. About 14% of our sample was unvaccinated but not willing to vaccinate, and another 14% were unvaccinated but reported being willing to get vaccinated. And if we look at that just among the unvaccinated, that amounted to about 50% of people that were still unvaccinated because they didn't want to be, so the vaccine hesitant population, and another 50% who wanted to be vaccinated but were not. So these are the people who we are saying had unmet demand for COVID-19 vaccines. So about half of the sample had unmet demand, according to our study. Next slide, please. So unmet demand was also quite variable across countries. A number of African countries had very high unmet demand, between 30 to 40% of the public. And in Western Pacific countries, because there was such high vaccine uptake, there was less variation to look at. But even there, it was a pretty even split among the remaining unvaccinated. Next slide, please. So we also looked at predictors of unmet demand in the countries for which there was this adequate sample to look at this. And what we found was that younger people, less educated people, and to a certain extent, women had higher unmet demand than others in the sample. In some ways, that was fairly unsurprising. We know that younger people were not prioritized. Less educated people might have a harder time getting access to vaccines. The fact that we found that women had higher unmet demand was a little surprising, because other studies have found that women have higher hesitancy in regards to COVID-19 vaccines. And also, surprisingly, we found that living in a rural area was not consistently associated with having greater unmet demand in the way that we thought it might be, but it was in certain countries that had high population living in rural areas. Next slide. So we also looked at, among the hesitant unvaccinated population, what were the contributors to hesitancy, and the three largest self-reported reasons for not being willing to vaccinate included: first, low risk perception from COVID-19, second, concern about adverse effects of vaccines, and third, perceived ineffectiveness of the vaccines. So in other words, complacency and low confidence in the available vaccines. So these were pretty standard reasons that other studies have also found support for. Next slide. So in summary, our main findings are that, especially in sub-Saharan African countries, there is substantial unmet demand for vaccines. And we think that this suggests that there are a variety of failures of delivery that are separate from hesitancy, that are preventing people from getting vaccinated. And so addressing some of those supply chain issues and figuring out how to make vaccines available and affordable for people based on need for vaccines is a future priority area. Thank you so much for your time, and I look forward to the discussion. And I think I'm passing it next to Bernard Black, Bernard Black. Thank you.
All right. So thank you. So this project was an effort to say, let's use Israel as a comparison for the US. Israel had an early, very effective booster rollout. The US had a slower, much less effective booster rollout, and try to use a mix of modeling and data to answer the question, how many more lives could we have saved in the US if we moved faster? And conversely, how many did we save by moving when we did, compared to moving even slower? Next slide. Okay, so this is joint work with co-authors, colleagues in Israel, Ali Tal-Kanan-Boker, Aharon Glatten-Friedman, Amnon Reichman, and colleagues in the US as well. And so what did we learn in 2021? The mRNA vaccines, which are the dominant ones used in the US and some other countries, were great. They were developed fast. They were highly effective. They were highly safe. But we learned fairly soon that the effectiveness of the vaccines waned pretty quickly within about 4 or 5 or 6 months. I'm going to suggest a better measure than VE when you're talking about serious disease is how much risk is left, which was remaining risk. And so what we learned was remaining risk rose, not only against infection, but also against severe disease. That should not have been a surprise, even though we acted as if it was, based on what we know about experience with other vaccines. So Israel was the first country to experience waning because they were the first to vaccinate most of their population using exclusively Pfizer. And so starting in June 2021, which is only not even 6 months after their first campaign, they had a new wave, exponentially rising infections, hospitalizations, deaths, and most of the hospitalizations and deaths were among the already vaccinated, almost all age 60 plus. They had to do something. They gambled with no evidence on a booster rollout instead of a lockdown. All they really knew was the booster was going to boost antibody levels. How it was going to affect disease rates, they didn't know. The gamble worked, the infection wave receded, and the third dose safety was excellent as expected. Next slide. That was a laboratory. Israel was a laboratory for the rest of the world. We were watching. We could have moved soon after they did. And other countries did move soon after, but the US dithered. Israel rolled out vaccines late July. Anthony Fauci said 4 days later, we're watching, they're getting really good results. We ought to do something. We had a broader public consensus among senior administrators 2 weeks later, and yet we didn't move until 2 months later. And even then, it was only partial. We approved boosters for age 65 plus for the most part, and there was really muddled public messaging about vaccines are still really good. They still protect you against severe disease. We only got full approval 2 months later in late November with Omicron on the horizon. Next slide. Okay, so this slide, the top left lines show for different age ranges. And I'm sorry that stuff got cut off on the slide. These are percentage vaccinated, okay? The x-axis is missing, the y-axis is missing. Israel is on the left. The US is on the right for different age ranges. The question we asked was, suppose you could move the US vaccination booster rate. This is for people who already got the initial vaccine, so they're not the vaccine refusers, toward Israel. How many more lives would we have saved in hindsight? Conversely, if we never did boosters, if you took the US lines, the lower right 3 lines, and just flattened them to 0, how many more people would have died? This is a combination of a modeling effort using the surprisingly poor US data and using the data that we've got. Our answer for moving at Israel's speed and their uptake rate was we could have saved 29,000 lives in ages 55 plus over the next year. Conversely, if we never authorized boosters, we would have had 41,000 additional deaths among the already vaccinated. For comparison, we had about 100,000 deaths among vaccinated over this period. We could have brought that down to 70, or it could have been worse at 140. Why? Next slide. Okay, so next slide. And one more. Okay, 3-letter answer, FDA. The FDA was in no hurry. Senior policy officials wanted to move. The FDA wanted to do its usual slow, methodical thing. We had pushback from senior FDA scientists saying, we don't want to be rushed. We're going to resign. We protest. Well, this is in the middle of a pandemic. We're going to have a next wave, even if we don't know exactly when. And we need the population to be boosted before we get there. And we, in fact, had excellent, overwhelming evidence from Israel. But the FDA didn't want to believe Israel. They wanted their own data. But the US didn't have the data because they're not good at getting it. So there's a message here for me and a lesson for the next time about the need for regulators in the middle of a pandemic to figure out how to move faster than they might move at other times. Next slide. So 3 more letters, CDC. We didn't have the data infrastructure in the US to measure not much of anything. We couldn't measure vaccination rates. We couldn't measure remaining risk against hospitalization or mortality. We couldn't measure waning, especially not in real time. And we still don't, and it isn't being built. And for me, it's the CDC's job to build it and to plan ahead. Next slide. That's really it. And so for me, this is both a data message and a regulatory message. Boosters worked. Now, in hindsight, we learned, yeah, if you're under 50, you weren't going to die after the initial vaccination anyway. We didn't know that at the time. But we did know that boosters helped over age 60. We could have moved faster. Other countries did move faster. And we had a regulatory apparatus that got in the way and a data infrastructure apparatus that got in the way and still gets in the way because we're not building the data that we need to build. And so many of you remember these little white cards that show that you were vaccinated. I don't know what other developed country was using little white pieces of paper rather than an electronic registry of who was vaccinated. You know, astonishing unwillingness to collect data on a national level to figure out who was vaccinated, who died, and so on. And that is relevant for the next pandemic. We don't know what it'll be, but we know we're going to need data to figure out what to do about it. And we ought to be working on building the data infrastructure now so that we're ready when it happens. Thank you.
Thank you very much. And first off, I'd just like to say thank you to Health Affairs for the opportunity to present the findings of our paper for you all. And it's an absolute honor. Next slide, please. So we reviewed 50 papers that looked at COVID-19 misinformation interventions. In total, we looked at 119 interventions as papers. Some papers included different studies in which there were multiple interventions tested. So on the right side of this, you can see kind of the distribution of different intervention types that were found in kind of the evidence base. And already you start to see kind of its substantial heterogeneity in the number of different intervention types being tested. So for example, there are many more passive inoculation, debunk, user correction, and accuracy prompt interventions compared to media literacy and active inoculation interventions. Now, the aim of this review is twofold. It was not only to better understand what interventions were potentially most effective at mitigating the impacts of COVID-19 misinformation, but it was also to interrogate the methods used to consider what constituted an effective intervention. And by that, I mean, what forms of misinformation were interventions being tested against? Were they more innocuous claims like gargling salt water would cure you from COVID-19, or were they more harmful content like injecting bleach would cure you from COVID-19? And we wanted to understand as well the mediums through which misinformation was being presented to participants, such as were they presented through audio? Was it text-based only? Was it video formats? Or was it image and memes? Next slide, please. So because we identified a wide range of outcome measures, there were 47 in total that we identified. And to make the evidence a little bit more approachable for public health experts and practitioners, we grouped outcome measures into several distinct buckets. So we have beliefs and accuracy judgments, we have quality of content shared, we have manipulation discernment, and we have measures related to public health. And in a review, we found evidence of debunking interventions helping to improve participants' beliefs and accuracy judgments around COVID-19 misinformation. We found evidence supporting accuracy nudges as a way of improving the quality of content being shared by participants. And while we did find evidence supporting other interventions that improved both beliefs and the quality of content shared, there was comparatively less evidence supporting these interventions when compared to debunks and accuracy nudges. We also found evidence supporting active inoculation, and some people think of that as kind of gamified interventions, as supporting and improving participants' ability to identify manipulation or manipulative content. And then we also found evidence supporting passive inoculation interventions as improving participants' intent to vaccinate. So kind of an important finding potentially for public health experts. However, and I cannot underline this, however, enough, while we would all like to have clean, tidy, and concise evidence pointing to one overarching intervention that solves the dilemma of misinformation forever, we don't live in such a fantasy world. And these findings come accompanied by other findings that complicate our ability to say decisively what interventions work the best against COVID-19 misinformation. Next slide, please. So as I mentioned before, there was substantial heterogeneity in the number of different intervention types tested. And not only do we identify a wide range of outcome measures, there were 47 in total, but we also discovered variation in the ways in which the same outcome measures were being evaluated, complicating attempts at comparing evidence and making sense of the evidence more holistically. Furthermore, only 18% of the interventions included public health related outcome measures like attitudes towards vaccines or intent to vaccinate or COVID behavior. There were few interventions that were tested over the long term, which limit our ability to say whether the effects of these interventions last beyond the actual study. And how these interventions fare outside of the US remains relatively limited. And despite more and more people consuming video-based content, including misinformation on platforms such as TikTok and YouTube, only 4% of the interventions presented misinformation to participants in video-only formats. And furthermore, the kinds of misinformation varied quite considerably across the studies. So for example, conspiratorial content related to COVID-19 vaccines was presented to participants only 9% of the interventions, despite conspiracy theories oftentimes being stickier and more resistant to correction than other forms of misinformation. Next slide, please. So based on these findings, we offer the following recommendations on how to advance research on misinformation interventions, specifically as it relates to the field of public health. Now, we need to include more public health experts, including local experts with context-rich knowledge in the development and implementation of interventions. We need to develop and agree on consistent outcome measures so as to make evidence more comparable. We need to test more diverse forms of misinformation, such as misinformation presented in video, audio, and meme-like formats instead of kind of text-only formats. And we need to acknowledge that misinformation is not a monolith. It can be explicit or implied. It can consist of different claims, framings, emotional valence. And the sources of misinformation vary widely as well. It can be a fellow social media user, or it can be the leader of a government. So we need to consider all these different facets of misinformation when developing a kind of more robust typology. Furthermore, we need to test interventions more internationally, and we need to invest in more research examining the impacts of interventions over the long term. Next slide, please. Now, if nothing else, what this review suggests is there is no silver bullet to COVID-19 misinformation. And ultimately, we need to be supporting research that looks at the impacts of community-driven interventions as vigorously and aggressively as we're doing with individual level interventions. Thank you very much. And I will pass it on now to, I believe David is up next.
That's right. Thank you, Rory. I'm David Ridley. As the slides come up, I'll tell you about myself and my co-authors. My co-authors are Emily Cuddy, who's a professor of economics here at Duke, and Yunpeng Liu, who's a graduate student at Maryland. Like the other papers in the session, we focus on COVID-19 and the pharmaceutical industry. And like Professor Black, we will be critical of some of the staff of the FDA, whom we believe are not going abroad like they should. But we'll also talk about other mechanisms for ensuring quality. Next slide. So I will always be grateful to the team at Health Affairs for holding briefings like this. 17 years ago, I participated in a briefing. It was not on Zoom. Zoom was still 5 years away from being founded. It was at the National Press Club. But it was because of a Health Affairs briefing that our paper became law. So I presented our paper proposing the priority review voucher, and a reporter who's now a medical doctor named Laura Blinkhorn came up to me afterward and told me some senators that would be interested, and they did, and it became law the next year. So for me, at least, these briefings are potentially very high impact. I'm not expecting that this paper becomes law, but I am grateful for the reach that Health Affairs has. Next slide. And I've got animation in these slides, forgive me. Thank you, Ryan. So in our article, we look at FDA drug quality inspections. We ask, how far have inspections fallen? And the answer is very far. They fell quite a bit during COVID-19, as you would expect. But the concerning thing is that they have not recovered, especially for foreign inspections, and I'll talk about that. We also look at other things like how far pharmaceutical imports have fallen. They have not. And we suggest some steps for FDA, Congress, purchasers, and patients. So this is not just about the FDA. This is about many more of us. Next slide. We obtained data from the FDA through a Freedom of Information Act request. So for several years, we've been acquiring information from the FDA, and we use that in the study. We also use some less granular, more current data from the FDA dashboard. Next slide. This is Exhibit 1 from our article. We plotted FDA drug quality assurance inspections over time. These are stacked. So you've got countries stacked on top of each other. So the total there is all the inspections in that month added up. I think the most obvious thing that you can see in this figure is that inspections fell with COVID-19 and they haven't recovered. Okay, in the next slide, I want to zoom in on the United States. So here you see domestic inspections. Domestic inspections are down 35% in 2022 compared to 2019. And in the next slide, you see foreign inspections, and you see that those have not recovered at all. So you see we've broken this down. We used the FDA regions. These are where the manufacturers are located, not necessarily the FDA people responsible. But you see a massive decline with the start of COVID-19, as you'd expect. But what's surprising is it hasn't recovered. Okay, what about 2023? That's the next slide. So these are more recent data from the FDA dashboard. They're more aggregated, more macro. But what you can see is that 2023 looks a lot like 2022, when it should look much more like 2019. Next slide. Here you see the share of inspections that have official actions indicated. So official actions indicated, OAIs, are the most severe outcomes for an inspection. And you see that those rose after the start of the pandemic. This is not entirely surprising. We'd expect this rise for a couple of reasons. Number one, I hope the rise is driven by selection, and that is that the FDA is focusing its few inspections on the most problematic establishments. If you focus on the most problematic, most likely to have problems, they do turn out to have problems. But another possibility is that with the more time that passes between inspections, the more manufacturers get sloppy, the more manufacturers shirk. There's plenty of previous evidence that with longer lags between inspections, there are more problems when the inspectors finally show up. Next slide. So there are a variety of reasons why the non-emergency inspections stopped at the start of COVID-19. Although it's harder to explain why they were not picked up. So obviously travel restrictions mattered early on. However, Mexico largely reopened in 2020, at the end of 2020, and FDA inspectors did not go to Mexico until 2022. So travel restrictions are not all of the story here, especially not in 2022 and 2023. And there were no decline in establishments, there was no decline in production, there was no decline in FDA budget or overall staffing. So FDA still had the resources, but its staff were unwilling to travel. Next slide. So policy implications, I have 3 slides here. So or several slides here. The first is that the FDA is going to need to prioritize foreign inspections. There's this massive backlog that it needs to catch up on. And the FDA will need to hire more staff who are willing to go abroad. This is not trivial. Many of the staff are unionized. Many of the staff don't want to spend a couple of weeks away from family for each inspection. Many of the staff don't want to relocate to India and China. So the FDA has offices in India and China, but they're perennially understaffed. It's hard to persuade staff to move, and that's understandable. As I understand it, part of the reorganization being led by Dr. Janet Woodcock it's manyfold. Part of it is having different people in charge of the inspections, but part of it is also hiring staff who are willing to travel, perhaps who even find it appealing to early in their careers get some international experience. Finally, it'll be important for the FDA to continue to leverage other resources. The FDA has conducted very few formal virtual inspections. Needs to do more, but not as a replacement for in-person, still needs the in-person as a complement. Also, mutual recognition agreements with Europe have been useful. Next slide. But the responsibility should extend beyond the Food and Drug Administration. So buyers should share in the drug quality burden. I mentioned here Kaiser Permanente and the Department of Defense. Both of them are not taking for granted that generic drugs are safe and effective. They are hiring outside labs to test drugs, test some of the most popular drugs, and then they are choosing the generic drug manufacturers who have the best outcomes in those trials. So they hire, for example, Valisure, who test their drugs. If some manufacturers perform especially well, then they say, aha, going forward, we will focus on these manufacturers. I don't have this on the slide, but this morning I watched the Senate Finance Committee briefing on drug shortages. And a vice president from Civica RX said, we focus on US manufacturers. And we can see from this that there's some reason for that, because FDA is also focusing on US manufacturers. So you know, at least some of them are being inspected. But also we pay attention to who makes the drugs that we provide to the hospitals within our network. So Civica RX is thinking very carefully about which drugs it supplies to hospitals. That Senate Finance Committee was all about preventing shortages. They're choosing reliable manufacturers to avoid shortages, but they're also thinking carefully about the quality of the drugs. We need more players like Civica RX, Department of Defense, Kaiser Permanente, not just assuming that FDA is going to do the full job, because they're not, but taking some responsibility for the quality of the products that are in the supply chain. One thing that would help more players pay attention to this would be if patients paid attention to this. So if patients knew that the FDA has inspected very few foreign establishments over the past few years, and that those foreign inspections are not surprise inspections. The FDA gives several weeks advance notice of an inspection. There have been a few exceptions. There was an experiment in India where they didn't give advance warning, but for the most part, 99% of these are given advance warning. American people should be aware of this and should think carefully about which generic manufacturers they're selecting. It'll be a hard shift for us, but it's certainly possible. When I talk about this in class, many of my domestic students say, yeah, I don't pay any attention to the label. And many of my international students say, of course I pay attention to who makes my drugs. So I think in some respects, we in the United States, or Americans, can be outliers in this and would be well served by paying more attention. Next slide, please. I showed you essentially two of our exhibits. There are two more exhibits in the paper, including one that's interactive. There are 9 more exhibits in the appendix. So thanks to those Freedom of Information Act requests, we've got a lot of data to share with you if you're interested. Next slide, please. So the FDA is doing incredibly important work. There's some wonderful public servants of the FDA. So I do feel awkward about picking on this in this regard, but some of them are not going abroad and need to go abroad, and the rest of us need to take more responsibility for drug quality. Next slide. So thanks to you. Thanks to Health Affairs for this opportunity, and back to you, Karina.
Thank you so much. Thanks to all of our speakers. That was a really exciting panel. I'm excited to move into discussion, question and answer. I'll sort of field questions to certain people, but if others also would like to contribute, please feel free. I had a question directed towards both Peter and Rory. I think your presentations together really highlight the urgency of addressing vaccine hesitancy and misinformation. Of course, you don't have a crystal ball, but I'm curious both of your sort of opinions about the hopes for slowing or reversing the trends that we've been seeing. And, you know, on a sort of optimistic note, what role might policy and policymakers have to play in addressing these issues?
Who do you want to go first?
Peter, go ahead.
Okay. Well, thanks. I think it's a two-pronged approach. I think, and it's one, improving the quality of health and science communication, but I think the bigger piece is combating the actors who are really creating a very predatory anti-vaccine movement. I think one of the things that concerns me is there's this kind of revisionist history going on that wants to blame the Health and Human Services Agency, saying they screwed up communication. That's why there's vaccine hesitancy, and that's false. Yes, there were things that could be improved, no question about it. But we have to identify the major source of this, which was a well-financed, politically motivated, predatory anti-vaccine movement that came out of the highest levels of the U.S. Congress, the House Freedom Caucus, some U.S. senators, and then this was documented both by Media Matters, a watchdog group, and a research group out of the Federal University of Science and Technology in Switzerland, ETH Zurich, amplified every night on Sean Hannity, Laura Ingraham, and Tucker Carlson, that during that Delta wave, when vaccines were widely available, filled their broadcasts with anti-vaccine content. And the point is, it's not some theoretical or academic discussion. It killed 200,000 Americans who refused COVID vaccines. They were victims of this predatory movement, overwhelmingly in red states, and the redder the county, the lower the immunization rate and higher the death rate. Hence, David Leonhardt of the New York Times just simply called it red COVID. This came out of research done by three groups, Charles Gaba, the health analyst, and among others, same with Kaiser Family Foundation. So how do you go up against that? It's the health sector is fumbling at that one because the health sector doesn't know what to do. And so what you see is kind of skirting around the edges, switching up computer algorithms on social media, and enhancing our health communication. All those things are good things to do, but they're going to get us 30 to 40% of the way there unless we do something about the predation, in my opinion. In terms of improving health communication, Operation Warp Speed allowed the pharma companies to communicate untethered, right? And what Moderna and Pfizer did, they sent out their press releases that do what press releases do. They're not meant for you or for me. They're meant for their shareholders to jack up their stock prices. And they wanted to spectacularize their accomplishment of mRNA vaccines, making it sound like they appeared out of nowhere. They didn't. They appeared out of 15, 20 years of research that we did on the spike protein, that the Penn Group did on mRNA. But by spectacularizing their accomplishment, it was tone deaf to the fact that it was frightening for the American people. And many said, well, how could these vaccines be legit? So one of the mistakes for Operation Warp Speed was not putting any constraints on how the pharma companies communicated to the public. Then, there were things that CDC and the other agencies could have done better communicating. They tended to use an old school way of communicating that says you have to talk to the American people like they're in the 4th grade or the 6th grade. I found that wasn't true. I found that unless you were full down the Joe Rogan and Fox News rabbit hole, that you were willing to tolerate a very high level of complexity, and I found that was more successful. So we do have to shift. We do have to provide instruction, ways to provide opportunities for medical students, PhD students, postdocs, residents to learn how to do health and science communication. We have to do something about offices of public communication and academic health centers that too often are in conflict with this. They want to do everything to keep the institution out of the headlines and discourage health communication among their docs and faculty. So that has to be done as well. But it's just a huge amount of work to do. So I'll stop there.
And I'll just speak briefly on from the intervention side. So I think ultimately we know that different initiatives are endowed a little bit differently, and I think it's a resource issue right now. I think everyone does really want an intervention that works for everything, and we have to acknowledge that that's never going to happen. And I'm a bit worried that most of the funding goes to individual level interventions as opposed to lots and lots of the really, really good community-centric interventions that are happening specifically in the most at-risk communities, such as Latinx and Hispanic communities and Black communities. And it's interesting as well that all of this happens in a local journalist vacuum, right? That's why people are overly relying on news streams such as Fox and Newsmax. And unfortunately, it comes down to where there's news deserts, oftentimes bad ideas seem to percolate in these communities. So I would, again, I think funding needs to be oriented not only at individual level interventions, because there are a host of really, really talented researchers doing phenomenal work. And again, I think we have to acknowledge that this field still is very young. It's still very much in its nascent stage. But that, funding needs to be prioritized both for individual level as well as the tons of good local journalist initiatives and other interventions that are happening at the community level. And I think, honestly, we're currently doing interviews with stakeholder audiences, primarily researchers, journalists, and practitioners. And what we seem to hear a lot of is that we also need to develop frameworks for evaluating these community interventions, right? So that we can provide evidence of their robustness and helpfulness in a way that these experiments done in lab settings are able to do, right? So whether that's through observational studies or whatever, but they definitely need help in terms of developing these evaluative frameworks. And I think that's also really important. We can't forget about that.
Great, thank you. I have a question for Bernard and David, especially given some of these comments about the importance of communicating during emergencies, the type of communication, the communicator. In both of your presentations, you talked about potentially sensitive policy decisions to be made and communicated. So in the case of Bernard, making decisions about when to roll out boosters in terms of timing of evidence. In David's case, how to communicate about drug quality from a regulatory perspective. And you can imagine that both of those are particularly challenging to communicate about on the backdrop of both an emergency, but also misinformation and anti-science sentiments. And so I'd love to hear both of your perspectives about if you have any thoughts on sort of how policy communication and policymakers might want to adjust the way that they message, should they adjust in this sort of backdrop of misinformation and the importance of communication that's come up several times on this panel.
So let me start maybe by seconding what Dr. Hotez said, which is the population isn't as dumb as the CDC acts as if it is. And we came out with a super simplified message. Vaccines are wonderful, don't worry, right? And then in 6 months, they weren't so wonderful. And we had to say, oh, gee, maybe they aren't so wonderful. Maybe you need a booster, as opposed to saying up front, they're wonderful right now. And in 6 months, we'll see. And we also saw one of the pushbacks for boosters was, don't tell people they need a booster because we're going to discourage other people from getting their first vaccine. And I remember being there in 2021 and thinking, this is just nuts. You are killing people who need a booster by not letting them have it and not telling them they need it, because you hope that if you don't tell them they need it, other people will get an initial vaccine. We need a way to have a more differentiated message that says, the need for vaccine really is very different for different populations. We still don't have that today, right? We still have the message of everybody should get the latest booster. And I don't even know if that's right under some age. I don't know if it matters. We don't have good data. It may matter for the elderly. Do we know that a fifth shot matters versus a fourth? We don't. Probably not a bad idea, but it's not like we actually know. But under some age, whether it's 40 or 45 or 50, if you've gotten 2 doses, and certainly if you've got 3, they're going to keep you out of the hospital unless you have severe comorbidities. And maybe you want to get another one, but you're just not in the same category as somebody who's 75. And we don't have that nuanced message. I don't know if I would recommend an mRNA vaccine to a 20-year-old man. There's not much of a risk of myocarditis, but there's also not much of a risk of COVID. And we don't have the ability to send that more nuanced message.
It's a fabulous question, Karina, and I agree with Professor Black. I agree with the value of nuance and communication, although it's hard. I understand why some government officials would worry about nuance, but I'm with Professor Black that we need that nuance. For our paper, the question is whether the FDA should acknowledge that not all generics are equally good. I think, and acknowledge that they're not inspecting every establishment. It could create panic. It could push people toward very expensive branded drugs. What I hope is that it will make them discern between generic drugs, that we Americans might be willing to pay a few extra cents to a manufacturer that has demonstrated high quality. I'm concerned that price competition is so fierce in the United States and US generics that it's a race to the bottom and nobody's paying attention to quality. And if we tell everyone quality is always good no matter what, then I think that's a problem. So I would like to see more nuance and more responsibility for purchasers.
Let me offer one more piece of nuance, right? All vaccines are not the same, even though we pretended they were, okay? So it turns out, we didn't know this at the time, that the remaining mortality risk for the first 2 doses from Pfizer through mid-2022 was about 2.5 times Moderna. CDC never told us that. The CDC's own studies suppressed the differences between vaccines and just reported average results for all mRNA vaccines. Did they not look? Did they not see? I mean, these are big differences that we were never told about. Now, why we have those differences, I can speculate that older people need the bigger kick that they got from Moderna. And our evidence also says once you get the 3rd dose, the differences shrink to statistical insignificance. But even today, there's a real lack of understanding that not all vaccines are not the same. And I won't even go into Johnson & Johnson because we kind of know that that's worse.
Well, I think, one of the amongst the problems was at least early on, the CDC's gotten better since, but early on they weren't measuring or publishing any kind of vaccine effectiveness data. So we were depending on Israel and the UK for all of our vaccine effectiveness data. And they had Pfizer. They didn't have J&J. They didn't have Moderna. So, if you got Pfizer, if you got the Moderna, you'd look at their Pfizer data and kind of try to extrapolate to Moderna, assuming it was similar. In some cases, yes, some cases, no. And if you got the J&J vaccine, you had buyer's remorse because, hey, nobody was publishing any data on J&J, and that was a problem also. The other thing that happened was, the vaccines were approved on the basis of effects on symptomatic infection, symptomatic illness. But then what happened was the Israelis provided data in early 2021 that the vaccines were also interfering with asymptomatic infection and actually halting transmission as well. And that was very exciting. And that's when the decision to take the masks off came about. But then what happened was with the change in the virus and the Delta wave, the levels of virus neutralizing antibody went down and you weren't getting that same level of interfering with infection and transmission anymore. And then the masks had to come back on. But the point is, it wasn't really explained to the American people the basis for it. So there was never that kind of underlying assumptions presented. And you're right, when the vaccines rolled out 2 doses and you're done. Well, no, I mean, we know from vaccines, pediatric vaccines, that what you do is you give a series of primary immunizations, you wait 6 months to a year, and then you boost. And And so what I was saying is, well, I don't know if it's going to be 1 and done or 2 and done. It might be 3 and done because of the boost. And during the Delta wave, I was looking pretty good. But because then you needed that boost. The problem was it turned out that the length of protection waned pretty quickly in these mRNA vaccines after 6 to 8 months, but that wasn't explained. So there was this, insistence on simplistic messages. And I think in what the CDC wanted to do was give one message for the American people. And unfortunately, we had 2 countries, one that was all in and wanted to do whatever it took to protect their health of themselves and their families. The others were all out and they weren't listening anyway. And so they amortized it with a single message that came out like baby talk. And I think that wound up backfiring.
We had the same problem with masks, right? We got the message, wear a mask. We didn't get the message, wear a respirator mask, as opposed to wear any mask. We got the message, wear any mask. And we knew better, right? We knew there was a difference between a properly fitted respirator mask, the N95 or the KN94, and the flimsy surgical masks that were sitting in lobbies all around.
Right. But I think, the point though is to say, yes, there were clear flubs in communication. My other point though was, even if the communication had been perfect, we'd still be in a similar situation, because the lion's share of what went on was this a very aggressive, politically organized anti-vaccine, anti-science movement that operated at the highest levels of the U.S. Congress. And by the way, it's not ending. I mean, now that the accusation's out there, the 200,000 Americans needlessly died, we're seeing this kind of revisionist history in place now, in which it's playing out in the House subcommittee hearings. I mean, on their official Twitter site, they even say they're selling popcorn, quote unquote. I mean, that's how awful it is. It's pure political theater. And they're basically trying to say, no, it was the vaccines that killed Americans, which is absolute nonsense, or that the scientists created the virus, which is absolute nonsense. This is revisionist history, and it's so damaging to our country, and it's putting it's so damaging to our biomedical scientific infrastructure. It's going to take us a long time to recover from what's going on right now.
I just want to bring this back momentarily to because we are talking about low and middle income countries in this special issue, and to bring this line of conversation back to low and middle income countries, it strikes me that the difference between the effectiveness of mRNA vaccines is like quite literally a first world problem, because a lot of the low and middle income countries, as our research showed, didn't even have access to mRNA vaccines. And so, our research can't tease this out, but I do think that it's an important question. How much of people's low uptake, especially where supply was more limited, was due to actually waiting for the more effective vaccines to maybe become available. In many low and middle income countries, the first vaccines that were available were the Russian vaccines or the Chinese vaccines, a lot of that driven by sort of vaccine diplomacy, those countries trying to get out ahead of the West, and the very slow delivery of COVAX, not really supplying adequate quantities in the right time frame for many low and middle income countries. So, just want to kind of bring this conversation back to that. And so I think there were people who were, waiting for better vaccines to become available in low and middle income countries. And, it wasn't clear, if you got the Chinese vaccine, would you then be eligible if J&J came along? And for many countries, actually, the J&J was a very good option that a lot of people were waiting for. So I just wanted to bring that into the conversation.
Thank you. And this has been a great conversation. I'm very sorry to have to end it, but I know we have a third panel that we need to get to. So I just wanted to thank all of our panelists for your work on the issue, your presentation today, your engagement in the discussion. Thank you to the audience members, and back over to you, Alan.
Great, thank you. We do have one more panel, and as they're coming together, I'll let you know who's on it. Before we launch the panel, I do want to note we had 2 papers that were originally slated for this panel that we did not. We lost our speakers for them. Thankfully, the papers themselves are available on the website, but we have a paper by Minaj and colleagues that describes a health justice policy tracker that looks at policies adopted around the world designed to advance health justice for vulnerable populations. And unfortunately, the author's not available. Similarly, Lasse Falk and colleagues wrote a paper on public perceptions of lockdown policies in Europe, showing that socioeconomic status did play a factor in how harsh people thought the lockdowns were, as well as trust also played a role. So again, sorry to not have those authors represented today, but want you to be aware of them. We do have three speakers who I'm pleased to have join us as we discuss vulnerable groups and protecting priority populations. Esra Aaron Bayendir is a research associate in healthcare management at the University of Hamburg. Jennifer Seeger is associate professor at the Milken Institute School of Public Health at George Washington University. And Cesar Gonzalez is a research scientist at the University of Texas Medical Branch. As with our other panels, we will turn to them sequentially to present their papers. We do continue, for those watching live, to have the opportunity to bring questions in from the audience. And we'll wrap it up with a Q&A before we close out the event. With that, Esra, I'll turn first to you.
Hi, thank you so much for the opportunity to present our work on socioeconomic disparities in all-cause mortality and healthcare use during the pandemic in Germany. This is joint work with Robert Messerle, Tom Stargard, and Jonas Schreier, all from University of Hamburg, Hamburg Center for Health Economics. And we thank German Research Foundation and Federal Joint Committee Innovations Funds for financial support. And I'd like to express our gratitude to Marcela Alschen. We benefited tremendously from her helpful suggestions and inspiring works. Next slide, please. Germany has a universal healthcare system in which 87.3% of the population, including welfare recipients, is covered by statutory health insurance, and 10.3% of the population is privately insured. In the German statutory health insurance system, solidarity with respect to both income and access to care is the guiding principle. Insured people generally contribute the same share of their income, and they're entitled to benefits according to their health needs. And patients can freely choose among almost 1,900 hospitals. Patient co-payments are the same across hospitals, and people can freely choose among the 185,000 general practitioners and specialists at almost 100,000 practices all over Germany. Data on education and income level of the population are publicly available at county level. Hence, we performed our analysis at county level using county level education and income. And there are 401 counties in Germany. Average population of counties is 207,000. Next slide, please. In this paper, we examined how all-cause mortality and inpatient utilization deviated from the pre-pandemic trends during pandemic's first 2 years by education and income level. We studied all admissions, respiratory admissions, AMI, stroke, and appendectomy as emergency care, breast and colon cancer surgeries, hip replacement and tonsillectomy as elective admissions, back pain, COPD, diabetes, heart failure, and hypertension as admission ambulatory care sensitive conditions. Next slide, please. This chart shows the baseline mortality and hospital admission rates for a selection of conditions for the sake of space. Here, low and high correspond to first and ninth deciles of the county level education and income distributions. And all-cause mortality rate is per 1,000 population. All hospital admissions are per 100 population, and the rate is per 10,000 population for the rest of the conditions. So the scale for all admissions and all-cause mortality are different, but the same for the rest of the conditions, just to be able to put them all in one chart. And in the pre-pandemic period, hospital utilization of the counties with low socioeconomic status was higher than that of the counties with high socioeconomic status in general. with the largest socioeconomic disparities in ambulatory care sensitive conditions, so diabetes and heart failure in our chart, which is presumably caused by higher healthcare needs of the socioeconomically disadvantaged population. One striking finding is that for the rest of the conditions, socioeconomic disparities were quite low, especially keeping in mind that we are comparing first decile to the ninth decile. Next slide, please. This chart shows the all-cause mortality and hospital admission rates for the pre-pandemic period and 2021. All-cause mortality increased and hospital use decreased for all socioeconomic groups, but education was more strongly associated with a change in hospital use than income. And the decline in hospital use was limited for the conditions we studied, except for ambulatory care sensitive cases. The impact of the pandemic was the most pronounced for the counties with low education and the least pronounced for the counties with high education. Next slide, please. Here we see the changes in socioeconomic disparities in all-cause mortality and hospital admissions from the pre-pandemic period to 2020 and 2021. Here, a negative number corresponds to an extra decline in hospital utilization rates for the relevant group. For example, for diabetes, hospital utilization of the counties with low education or low income decreased more than that of the counties with high education or high income in both years. So the changes in socioeconomic disparities were limited, except for the ambulatory care sensitive conditions, for which the socioeconomic disparities actually decreased during the pandemic. And in general, education was more strongly associated with a change in disparities than was income, which might be partly caused by the lower variation in income than in education in Germany. Next slide, please. So we think that the universal healthcare system and the presence of a strong social safety net might have helped mitigate the impact of the pandemic on all-cause mortality and large segments of healthcare use in Germany. Additionally, our findings underline the importance of education. Hence, more guidance to the population with low health literacy might help further diminish the socioeconomic disparities in healthcare use in Germany. Thank you so much.
Thank you. Jennifer, over to you.
Thank you. So I'm presenting our work looking at the impact of COVID-19 pandemic restrictions on adolescent social outcomes. And just to give a little bit of background, while we know that adolescents were less susceptible to COVID-19 related morbidity and mortality, the social containment policies to curb the disease really had some large impacts on their everyday lives, right? So these policies included stay-at-home orders, and most importantly for these adolescents, potentially as the closure of schools for extended periods of time. And in LMICs in particular, the limited access to technology, low provision of resources by schools, these school closures could have sort of greater repercussions on adolescents. And in a couple of settings that we're focusing on today, Bangladesh and Ethiopia, there is also a large concern that with school closures and economic instability, that there may be some impact on early marriage in these settings. And so you can go to the next slide, please. So what we do is we use panel data on 7,000 adolescents who are living in Bangladesh, Jordan, and Ethiopia. And they were all surveyed prior to the pandemic and at 2 points during COVID-19, once early in the pandemic in, say, May to July 2020, and then once later in sort of late 2020 to April of 2021, depending on the context. And the baseline or the pre-pandemic surveys, depending on country, in Bangladesh, they were between 2017 and 2019. In Ethiopia, it was about 2017, Ethiopia for this paper was in 2020, late 2019, early 2020, so right before the pandemic, and then Jordan was in 2019. And what we do in the paper is we look at first just changes in adolescent outcomes from baseline to these two different points in the pandemic. And then we use sort of a difference in difference framework to then compare these changes between adolescents that are more and less vulnerable to the COVID-19 pandemic. And we also look at differences between adolescents who had access to social safety nets through government and NGO provided aid and sort of mitigating these negative impacts. We do have about 5 different samples that we're looking at here. So in Bangladesh, we have a sample of adolescents who are living in Dhaka, so living in urban slums and low-income neighborhoods, and 2 populations that are living in Cox's Bazar, which is one of the poorest areas of Bangladesh. Some Bangladeshi adolescents that are living in communities that are nearby refugee camps, and then a sample of Rohingya refugee adolescents who are living in the camps in Cox's Bazar. In Jordan, we have a sample of Jordanian and Syrian adolescents, and we separately consider those adolescents who are living in integrated into Jordanian communities versus those who are living in camps. And then in Ethiopia, we're focusing on an urban sample of adolescents. And so we'll show sort of results separately by each of these samples, but it also allows comparison of sort of refugee populations and host populations, and also those in more rural settings versus more urban settings in Dhaka and in Ethiopia. Next slide, please. So here I have a few slides that we're going to be looking at some figures with results. And so as a reminder, when we talk about COVID round 1, we're really thinking about May to June 2020. And we're talking about COVID round 2, we're looking at early 2021. So close to a year after the initial lockdowns. The other thing to note, in each of these countries, there were immediate sort of large scale lockdowns that occurred in March 2020, that in most cases, the most strict restrictions were lifted in about September of 2020. So you can also think of these 2 time points as COVID round 1 being during the time of the strictest market closures and lockdowns. And the second time point in early 2021 as being, there were still some restrictions in terms of masks and things, but the markets weren't shut down to the extent that they were in the immediate start of the pandemic. And the other thing that's true in Bangladesh is that, and in Jordan, in Bangladesh and Jordan, is that schools remained closed through both of these periods. So what this first figure is showing is just the difference between baseline and COVID measures. And what I want to highlight is, first of all, we see large decreases in the amount of time spent studying. And I think like particularly in Bangladesh, there was very little provision of any type of learning activities from the schools to adolescents at home. There was a broadcast television channel that showed the national curriculum, but there have been studies, and our own data have shown that 10% or less than 10% of adolescents actually accessed those. And so that's really what's driving this reduction in time spent studying. The other thing I want to sort of draw attention to is sort of large, the bottom measure that we're looking at here is share of meals with protein, which is what we use to proxy thinking about adolescent nutrition or food insecurity. And we see large reductions in the share of meals containing protein, which is more broadly aligned with other outcomes that we looked at that indicate increased hunger among adolescents as well. And so we see both that there's a large immediate impact, which may be expected due to reduction in market movement, but also we see that these impacts are surprisingly largely sustained when we then look at COVID round 2, and we still see sort of equally large reductions at a time when the conversation thought that these countries should be in recovery, right, because of markets being reopened. Looking at paid work, I think it's unsurprising. We wanted to look at, due to economic insecurity, whether there were any negative, if there was an impact on adolescents working more during the pandemic, but due to the closures in the markets and the fewer job opportunities in general, we do see reductions in engagement in paid work. Next slide, please. So then, as opposed to just looking in general at the changes from baseline to COVID, we wanted to look at whether adolescents that were more vulnerable had worse outcomes than those that were less vulnerable, keeping in mind that all populations that we look at here are vulnerable. And so what we see is that more vulnerable adolescents had larger decreases in the share of meals with protein. And in Jordan in particular, we see that they were less likely, they spent less time studying. And in Dhaka, we have some evidence that that adolescents were more at risk for early marriage, particularly in the later period. So there is some evidence that adolescents who are already at heightened risk suffered more. Next slide, please. Here I'm showing differences in changes in outcomes according to the receipt of aid. I think one of the takeaways here is when you just look on average, adolescents that received aid were not seeing any differences in nutrition in the immediate period, suggesting that aid was not sufficient in the immediate period during lockdowns for food insecurity, though we do see some positive impacts in the Cox's Bazar Rohingya sample and in Ethiopia urban. But in general, we're not seeing that adolescents who received aid are doing better than those who did not. Next slide, please. And then if we further restrict to just look at whether aid was being targeted toward the more vulnerable adolescents, we again see that even among the more vulnerable adolescents, aid is not having much of an impact, with the exception of improvements in food security and access to meals with protein during COVID round 2 in particular. So there's limited evidence that aid receipt was protective for adolescents, regardless of their vulnerability status. And so then just to conclude, I think overall, our takeaway from the paper is that, the social safety net programs, which tend to focus on these poverty alleviation, are insufficient to reach the most vulnerable populations. And they're not responsive to age-based needs. And so we do need to think, if something like this were to happen again, how do we bridge this gap during for young people? While aid did mitigate the negative impacts related to food insecurity, consistent with the fact that the predominant type of aid was food aid, we do not see similar effects for other critical dimensions. And I also think, if we think back to that first slide, looking at the negative impacts, I think it's notable that there was such a persistence in these negative impacts beyond when the restrictions were lifted. And so we are continuing to collect data with these adolescents and starting to look at data collected in 2022 and 2023 to see what's further happened with these trajectories. But I think, just I'm very happy to share these results and looking forward to having further discussion to sort of unpack what we have here. Thank you.
Great, thank you. And Cesar, over to you.
Thank you, good afternoon. It's truly a pleasure to be here presenting the key findings of our paper titled COVID-19 and Mental Health Outcomes of Older Adults, Evidence for Mexico. First, I would like to thank my co-authors, Deb de Graaf, Karina Orozco, Rafael Samper, and Rebecca Wong. I also appreciate having the opportunity to present our paper in this virtual forum organized by Health Affairs. Next slide, please. Since this is a Data Watch manuscript, please allow me to highlight some information about the Mexican Health and Hygiene Study, the MHAS. The study started in 2001, is a national longitudinal study of adults 50 years and older in Mexico. The fifth wave was carried on 2018. Meanwhile, the sixth wave was carried on between November and December of 2021. just before the third peak of the pandemic in Mexico. So the potential impact of COVID-19 in other dimensions, for example, mental health of older adults' life, is captured with the MHAS study. The MHAS content includes health in multiple domains like the socioeconomic conditions, family background, income, assets, time use, and psychosocial aspects, and for the disease participants of the study, the conditions in the last year of life. Now, going back to our paper, before the pandemic, we were analyzing changes in the mental health of older adults, given that M has already had information in 2012, 2015, and 2018. At the end of 2021, the impact of COVID-19 on mental health can be established. During the early stages of the pandemic, as pointed out by several of the papers before I was presenting, the mental health of the population worsened. Everywhere, the lockdown and social distancing policies have an adverse effect on depressive symptoms, loneliness, and life satisfaction. Mexico was heavily affected by COVID-19, ranking 7th worldwide in reported deaths and 2nd in the confirmed case fatality rates. In addition, the management of the pandemic in Mexico was somewhat chaotic, with hospital bed saturation, long waiting times to get healthcare services, and a shortage of medicines. This combination of an adverse context and the new COVID-19 epidemic produced negative consequences on the mental health of the older adults population. In this article, we are looking at the effect of COVID-19 on 4 mental health outcomes, such as depressive symptoms, loneliness, life dissatisfaction, and foregone health care. The figures in parentheses correspond to the 2021 prevalence. Next slide, please. Our paper includes 2 COVID-19 variables: the report of diagnosed infection and experiencing at least one of the 4 COVID-related major adverse events: death of a child, death of the spouse, taking care of a sick family member, and affected financial situation. Being able to compare the effects of 2 COVID-19 related variables opens the possibility to complement the results and the conclusions. On one hand, the infection that has an acute component with probable side effects on physical health, and in the other hand, 4 major events with long-term effects and greater impact on the mental health of older adults. Next slide, please. Something that we have found with MHAS is that the levels of mental health variables remain constant over time. This is the case for loneliness and depressive symptoms. Meanwhile, life satisfaction showed a clear decline between 2018 and 2021. And foregone healthcare showed a gradual and constant decrease over time. At first sight, there is no increase in the prevalence of negative mental health outcomes. Next slide, please. But when we look the differences by COVID-19, our results show an increased probability of depressive symptoms and loneliness among those who experience COVID-19 infection, and even a higher probability of negative mental health outcomes among those who experience a major adverse event related to COVID-19. And when we look at sociodemographic characteristics, the COVID-19 has a greater effect on women, on those with lower or non-formal education, and those who live in urban communities and among the youngest older adults. So what are the lessons that we learned from the COVID-19 pandemic? Older adults in Mexico are a vulnerable group. Thus, they are heavily affected by COVID-19. The disease increases the risk for negative mental health, and the risk is exacerbated by the report of a major event. We found that using complementary variables like the one for the diagnosed infection and major related events allow us to better understand the impact of COVID-19 on mental health of the older adult population. Thank you.
Thank you. Well, thank you to all of you. And of course, the details of what each of your papers focus on are quite different settings and different topics. but it seems to me they share a theme that I'd like to try to bring out. All of them are the intersection of equity and protection of vulnerable populations and a shock to the healthcare system, in this instance, of course, the COVID-19 pandemic. I wonder if each of you would do me the favor of providing a little context, specifically in the geographic area of your study, of the degree to which there has been a sustained attention to the dimensions of equity that you studied, and whether or not you're aware of any similar analyses through other healthcare shocks. COVID-19, of course, is a horrible shock in many ways, but not the first challenge these health systems have faced. So I wondered if maybe just in the order that you presented, you could provide me with a little bit of context. Ezra, could you tell us a little about those topics and their history in Germany?
Our paper is in Germany. So actually, I've been living in Germany for 5 years, so I'm not quite familiar with the history. So I wish Jonas could have helped me, who is the healthcare expert in Germany. But given the strong social safety net and the universal healthcare system, the vulnerable population, so there is inequalities in healthcare use and access, but when we look at, for example, the hospital utilizations, we see it the other way around. For example, the healthcare utilization or hospital utilization of the more vulnerable population is higher, which shows that they have higher healthcare needs. So, and these are met in the hospital. So it can be good. So in a sense, it's a good thing that their healthcare needs are met at the hospital, but some of those are ambulatory care sensitive cases, which could have been prevented. So there is still some room for improvement. So, which means that despite having a universal healthcare system and a strong social safety net, still there are some socioeconomic disparities, mostly by education level, but compared to other countries, which are quite insignificant, I think. And unfortunately, I'm not very familiar with the previous shocks.
That was very helpful, not to worry. Thank you. Jennifer?
Yeah, thank you. So I will say, we have a large team of co-authors working on this paper, and I am part of the data collection. I mostly work in Bangladesh, so I can maybe speak a little bit more to Bangladesh, more so than the other contexts. What I will say is, historically in Bangladesh, even when we initially started doing data collection in 2017, thinking about these social safety nets, is we did not identify many, and most of the social safety net or like aid systems that were in place are more of a provided by NGOs that we've been able to identify, more so than having sort of a national government overarching. So for the pandemic, there was a movement for government to provide aid, although our data is showing that aid really only reached like 10% or so of the samples that we're working with, which are, again, more on the vulnerable side of the population. And so in addition to the work that we've done, there have been other studies in Bangladesh looking at the reach of these social safety nets that have largely found that these programs were not sufficient in general, not just looking at sort of the impact on adolescent populations. So I guess maybe I'll leave it at that.
That's great. And Cesar.
Okay. I think you are right. The inequality, the equity, that's something in the middle. And the context of Mexico. Mexico is a very diverse country. It's a very populated country. We have 127 million inhabitants, and of them, maybe 50 million are aged 60 plus. So as I pointed out in my presentation, there is a lot of inequality between some groups, for example, women, the less educated, and we have a fragmented health service system that doesn't allow to get access to health services of quality. And of course, we have a huge heterogeneity in the 60 plus population. And now we are having population from 60 to 69 that maybe are very different to the oldest olds. And it's imposing a challenge to tackle the inequality and how you can access to the health services in Mexico and try to not making vulnerable the population from the COVID-19.
Thank you.
So if I can just say
Please.
a few things. Jonas just reminded me about the refugee crisis that Germany experienced in 2015 and 16. So Germany experienced a huge influx of refugees during that time, and more recently in 2022 as a result of the Ukrainian war. So actually we are looking at the impact of the refugees on German healthcare system in a recent project. And our preliminary findings suggest that the access to healthcare, for example, was not adversely affected by that influx of refugees, but some of the hospital outcomes, mostly nursing sensitive outcomes, were adversely affected to a limited degree due to that demand shock. But yeah, that's all that I'm aware of. And
that's very helpful. Thank you. Received a question from the audience that I think, Cesar, is probably for you, because it's asking about mental health, and it asks about is it possible to disentangle the effects of mental health from the burden of COVID and all of the other things that happened, as a result that were very socially disruptive?
My first thought is yes, but we have to look into the data, because for now we are looking at the effect of COVID, and we have two variables, just infection, and this is something that maybe is acute, as I said in my presentation, and then we have major events, the death of a child, the death of the spouse, and having a bad economic situation because of COVID. And maybe we can disentangle, but it's for another paper for the next time, and we have to look into the data. And as Jennifer said, MHAS, and I said with the MHAS, it's a longitudinal study. So in 2024, the study is going back to the fieldwork, and we can have the trajectories or the effects of COVID, and trying to see if we can disentangle what part is due to COVID and what is part of some other elements of the dimensions of life in the elderly population in Mexico.
Great. Well, I'm going to close with a question I don't know if you can answer, but it's been on my mind since the very first panel, where there was so much emphasis on models and modeling results and its relationship to policy. I wonder if any of you saw dimensions of the modeling or the efforts to sort of describe the trajectory of COVID with an equity dimension, which isn't something we really talked about at all in the first panel. So did you see models paying attention to inequities? Did you see them helping address or predict inequities, or not? I'm just curious what you might have observed in that regard.
I was thinking in mortality, inequity is best reflected in mortality, and I was thinking on life expectancy. If we can, since MHAS is asking for those who died between 2018 and 2021, and if the cause was because of COVID or disease related to COVID, maybe we can start thinking on how COVID affects life expectancy in 2024, or between 2018 and 2020 and 2021, but I don't know if we have enough sample right now to start working on this inequity, because the healthcare service access in Mexico was really a huge difference for a lot of population that dies because of COVID.
Other thoughts on this, either of you?
I'm not sure this is really an answer to the question, but it made me think about, in our study, we're looking in some ways at sort of, changes in outcomes and then comparing the size of change compared to whether households are more vulnerable or not, as we define it. And one of the things that I think is lost in the fact that, many of our findings is not that there's big differences in the impact of COVID by vulnerability status, but it's still important to remember that the more vulnerable households largely started at a much lower point, right? And then saw the sort of same size negative impacts as those that were doing better. And so the question is, and not something that we explored closely in this paper, but then is thinking, that end point where they are now, like where does that sort of push those households to thinking about what's possible for those adolescents moving forward, and whether they've been pushed sort of below, I might want to say like a poverty traps type status that may be more difficult to pull out. And so that all sort of makes me think about when you're modeling sort of the long-term impacts of this pandemic, that it may be that sort of more vulnerable households are really on a completely different trajectory than the better off households. But
it's very interesting. An area for exploration. I think that's quite interesting. Ezra, anything on the modeling?
So I think it's quite complicated to include that equity or inequality. I mean, inequality is the easy one, relatively, but especially equity, because it's quite difficult to measure and to have a common accepted measure for equity at first. And I'm not aware of any studies that has looked at that, fortunately.
Okay. Well, I want to thank you all for your papers and presenting them so well, and for elevating this dimension of the COVID pandemic that played out, of course, around the world. So thank you for that. And I will now close out our event. Let me just say a few things. I'm really thrilled that we were able to cover so much of the content in the issue, and it is open access. Want to acknowledge the Robert Wood Johnson Foundation and the Merck Foundation for their financial support, making the issue and all the event and many other activities available to you as well. And of course, I've noted our theme issue advisors, Mark Jitt and Corinna Musharod, and our editors, Meg Winchester and Margaret Saunders, all of whom and many others at Health Affairs making this possible. We do have additional content associated with the issue. On Tuesday, December 19th, we have a journal club with Ashley Fox, who joined us today, who will discuss her paper with our editor, Margaret Saunders. And on Wednesday, December 13th, we'll have a lunch and learn on the global impacts of PEPFAR and consequences of deprioritization. That will be with Dr. Tom Kenyon, who's the Chief Health Officer for Project Hope, which is the publisher of Health Affairs. Today's event was open to all. We do have an insider program called Health Affairs Insider. It provides you with exclusive access to content that goes beyond the journal. And you can sign up for that on our website. You'll gain access to events, newsletters, and other activities. You can find more information about that on our website. Again, with thanks to all involved in the efforts to get us here today. We hope we've elevated your interest in this topic and your understanding of it, and we encourage you to continue to explore the great articles that are published in the December issue. Thank you for joining us, and with that, we are adjourned.